manufacturing, education, retails, and much more. I would like to thank the program committee for designing the entire program structure, that is Mr. Chris Gopalakrishnan, Mr. Vijay Kumar Ivaturi, Dr. Gopichan Kattakatta, and individual session coordinators for continuous support and inputs. I also like to take this opportunity to thank all the companies who have been associated with us for the summit. 3M India Limited, Infosys Limited, Tata Group, Capgemini India, Tata Hitachi Construction Equipment Machinery Private Limited, GE, Wipro Limited, Tech Mahindra, Tegutech India, Software Technology Parks of India, Volvo India, State Bank of India, Bridge Hub Private Limited, and Velepa Software Technological Part Private Limited. With this, I also take the opportunity to thank all the exhibitors who are showcasing their products through the virtual exhibition. I would also like to thank all the speakers for the confirmation to take their time out from the busy schedule and participate for the summit. As we proceed to commence with the session, evening session, I would like to kindly request all the attendees to maintain the decorum of the conference, request all to mute their speakers, and pose their questions in the chat box. Also, to all participants, the summit also comes with a virtual exhibition and corporate library to augment the discussions over the coming days. For the evening session, I welcome you all again on Rethinking Health and Wellness. For the program coordinators of the sessions are Dr. Ravi Ramaswamy, Director Philips Innovation Campus, and Mr. Manjunath Kukru, Associate Vice President and Principal Research Analyst, Infosys Limited. The session theme focuses on the innovation and healthcare sector. I welcome for the first evening discussion under the session Managing COVID at Scale, Challenges, Learning, and Way Forward. It's going to be an exciting fireside chat between Mr. Manjunath Kukru and Dr. C.N. Manjunath. Over to you, sir.
Hello. Hello. Should I start speaking?
Yes, sir. We can hear. We can start speaking. Thank you.
Yeah. At the outset, I'm very thankful to this Confederation of Indian Industry Resilience on Health and Wellness, and also in India Innovation. This is a well thought program. See, always innovation comes only when things are not available around. That makes us to think always. If things are easily available in front of us, for example, I am having 2-3 private secretaries. Still, I don't know how to really operate a lot of the other complex problems of a computer or even a mobile phone. So many applications I am not able to do. So the same thing. So this COVID-19 pandemic has virtually, has paralyzed the life, has paralyzed the livelihood, it paralyzed all sections of the society, starting from A to Z. So in this context, we need to balance both life and livelihood. On one side, we are also scared, worried about the life losses. So at this point of time, India is facing, or the world I can say is facing 4 or 5 threats. So this we can call it as a global threats. One is this, particularly this COVID-19 pandemic is one. As a consequence of COVID-19 pandemic, we are having what is called loneliness syndrome or isolation syndrome, that is really causing a lot of health related issue and social issues. Then we have on the other side job losses, and also the economy is also another, economy issue is on the other side. Then we have weather and water crisis. Then we have lifestyle diseases. So these are some of the important threats. The world is facing at this point of time. So as far as COVID-19 pandemic is concerned, so we have traveled nearly 7 months along with this virus, and we have learned a lot of lessons. and also it is also giving a lot of new lessons also. As a result, the problem and challenges of managing this COVID-19, because always whenever there is a pandemic, the nature is always ahead of technology. Whatever you do, nature is one step ahead. See, this is what a popular saying: a man cannot change another man easily, but nature can change a person today. See, for example, nature is forcing us to wear a mask, which earlier we were not really happy to wear, and it has also forced us to talk from a distance, what is called physical distancing, and also forcing us to wash our hands frequently. So this is how nature is always ahead of technology. The biggest challenge of this COVID-19 is it has got a very high infectivity or a contagiousness. So this is where the problem of controlling and containing this menace of this virus. So as far as health challenges are concerned, one is the demand supply mismatch, because none of the countries, and it's also not practical to keep your health infrastructure ready to really combat and also to treat such lakhs and lakhs of patients who are pouring in globally. So obviously, there is a great demand and mismatch, a supply mismatch. So when we started somewhere in March, actually in India, that's where we started seeing some cases. All of a sudden, the international flights were cut off. Even the interstate and the interdistrict and flights, I mean, the vehicles transport was cut off, and lockdown was, enforced somewhere in March 23rd, if I am correct. Yes, March 23rd, lockdown was enforced all over the country, and it went on and on. So the biggest problem, the idea of imposing a lockdown is to really prepare ourselves for this pandemic in anticipation of surge of cases going by the natural course of this illness, both in Italy at that point of time, Spain, also America and some European countries, particularly United Kingdom. So the immediate challenge before us was how to really narrow this demand supply mismatch. So immediate concern at that time was, even there was a short supply of PPE, there was a short supply of your mask, all, whether it is a 3-layer mask or maybe an N95 mask, or even for that matter sanitizer, because China had given us virus. Unfortunately, they were also giving a lot of raw materials to treat this virus, whether it is PPE or whether it is all those things. So this has opened up a tremendous opportunity for Indian industries, whether it is a textile industry or whether it is other, particularly pharma industry, to put their, weight behind their research, initiatives, so, to see how best they can cope up. So if you look at the cost of these materials over a period of time, as we have walked from March to September, the cost of all these things has come down, whether it is a PPE or whether it is sanitizers or whether it is, even for that matter, the masks, everything has come down. So the textile industry and also the garment industry has taken up this challenge, and they started manufacturing, because ultimately they were jobless because of the lockdown and also because of quarantine issue, because of isolation issue. So this is how, so the Indian textile industry took a lead and started producing this masks as well as PPE kits. Today India is, I heard, they are exporting some PPE kits, and they are also ready to export this masks of all categories, whether it is a 3-layer mask or whether it is a N95 or N95 prototype of mask. Then the distilleries, distilleries also started manufacturing, producing sanitizers. We all know distilleries always they produce ethanol-based products. So this is how the crisis ultimately has become an opportunity. So always, if you think in a positive perspective, the problems, yes, can become an opportunity, and otherwise, and always you can find out new solutions as emerge. So another thing that has happened was, of course, the WHO also has said you have to do three things to control and contain this pandemic. That is, you test, test, and test. This is what WHO has said. So initially, Karnataka was doing around, say, 5,000 swab tests a day. Today, we are doing about 70 to 75,000 tests, and India is doing around 1 million tests daily. So for this, there was a problem initially because we need, of course, there are three types of tests. One is an RT-PCR test considered to be the gold standard. Then we have second, we have a TrueNat. In fact, TrueNat is India's innovation of testing this virus. Then the third, we have a rapid antigen test. So all these things have been responsible for scaling up and ramping up these particular tests. So today, yes, we might be seeing more cases because we are testing more and more. But if we test more and more, obviously, it is helpful in early isolation. It is helpful also in starting early treatment for needy or moderately sick patients. So the problem before us today is, yes, it's very difficult to control the number of cases coming up, but the objective health challenge in front of us is how best we can reduce the fatality rate. So fortunately, compared to either Spain or maybe compared to even United Kingdom or United States, fatality rate in India is less than 2. In our state, it is around 1.3, 1.4%. But one of the another important challenges is to have more number of ICU beds, because even if India, for example, you take 3% requires an ICU admission, going by number of cases, India alone requires about 1,25,000 to 1,50,000 ICU beds. So this is one of the concerns. We know that 90% of COVID cases do not require any ICU admission. They get well on their own or get well on with a very simple treatment. About 6 to 7% require oxygen beds, and about less than 2% requires ventilators. That's what the statistic says. So in that line, all across the country, district hospitals, taluk hospitals, and medical college hospitals, their bed strength was reinforced. ICU beds were reinforced. Many before this corona, only they had just 20 or 30 bed ICUs. Now it has been expanded. Even you go to any district hospital, either in Karnataka, or I strongly believe same thing in other parts of the country, is now each district hospital have somewhere around 100 to 125 ICU beds, and as a result, the health infrastructure is reinforced in the name of COVID. Definitely, this facility can be utilized in a better manner in years to come, whether any pandemic comes or even otherwise. So some of these sick hospitals which were deprived of these facilities has been upgraded because of this COVID. So now most of the hospital across the country, public hospital, have got more ICU beds, they have got more ventilators, they have got high flow nasal oxygen system, and also now oxygen is another important thing. Probably this is where our innovation, our industries have to put their hands. We need more and more of oxygen, because there are only 4 or 5 players who are supplying or manufacturing oxygen. because this pandemic will never end immediately. Even hopefully it might start coming down by October, November, but it will be there all through the year. Some people predict even it might slip into the next year also. So the need of the hour is to have more oxygen plants so that a common man can get this oxygen at a subsidized rate, and the whole treatment, ICU treatment, should be cost effective. So oxygen is a real issue because already we are seeing short supply of oxygen in many places. So this is where I appeal to many industrial giants as a part of this symposium. They can always think over and see how best they can go ahead and supply oxygen. Then again, the critical care preparedness was also further strengthened. Today we have more CT scans because today's CT scan is also an important investigation. Many a time it has so happened, patient has symptoms of COVID, your RT-PCR tests are negative, but the CT is typical of COVID. So CT scan, many hospitals are getting new CT scans across the nation, and probably CT scan is also important. Then X-ray, because X-ray also, we have what is called digital X-ray nowadays, because unfortunately, because of very high contagiousness of this, very difficult for the X-ray technicians to go repeatedly towards the patient and washing these films. We have digital X-ray. It comes like a photograph. Immediately you can take X-ray, you can read X-ray, no need for washing. So this sort of innovations have really added to the comfort of both the patients as well as comfort of healthcare warriors, because we all know that healthcare warriors are at highest exposure risk, and many more than 700 doctors have already led their life in this fight, and many more healthcare workers have been affected. So the X-ray innovation also has helped to a greater extent. Another biggest challenge what we have is a manpower. So yes, we have money. Yes, we have got that political will. We have that bureaucratic will. Yes, the bed capacity is increased, and also the supply chain is also improved. Unfortunately, to get manpower, it's also a biggest challenge, because we need more doctors, we need more technicians, more nurses, and also we need a lot of supporting staff. And there is always a fear psychosis among everybody, including us, because of fear of catching this infection. And many are getting infected while treating, and they have to go on quarantine. Somebody has to replace them. So getting manpower is also extremely difficult and a challenging one, but somehow it has been managed. Some incentivization also has been given to the healthcare workers, like Paura Karmikas or ward helpers. They have been given some additional remunerations. If you look at the health scenario, the hospital or medical college scenario in the country, apart from going from this pandemic issue, see, 40% of population live in southern India, but 60% of medical colleges are located in southern India, while 60% of population lives in north and northeast, but only 40% of medical colleges are in north and northeast. So there is a maldistribution of medical colleges in this country. And another important lesson what we have learned from this: building alone, equipment alone will not be sufficient to provide a quality care to a cross section of the society. It is manpower is equally important. So our focus should move from construction to creation of posts. In many places, or in many governments, whether it is government, federal government or the state government, main focus they are giving for construction and equipping them, those hospitals, but unfortunately left out is creation of the post. So building, again I re-emphasize, building alone, equipment alone will not deliver the services. And most importantly, we need to create parallelly manpower at all levels, both at the doctors level, maybe nurses level, or the technicians level. And public-private partnership is extremely important. It is not possible for the government to do everything on its own. For example, in our own institutions, we have a public-private partnership for running our MRI, even our CT scans or CT coronary angiogram, and even our nuclear medicine gamma camera is on a PPP model. So I think this is where the government as well as the private players, particularly industries, have to come together. Then it can provide a cost-effective treatment. So even as far as testing is concerned, in Karnataka, maybe till April, we had only 10 testing labs. COVID-19 testing labs are only 10. Today, we have close to 130 testing labs. So they have been ramped up. RT-PCR machines are available. And indigenously, some of the kits are also developed. So a lot of innovations are also coming. Some people are telling we can detect this virus by different technology, which is a very cost effective. Yes, it has all started, but the end product might take some time, but it has set the pace for detecting the virus. Apart from this RT-PCR methods, some light amplification method I heard. So many, even Indian Institute of Science is doing something, and definitely the public-private partnership should take an important step, because otherwise government machinery alone will not able to give the all sufficient services. And I'm very also happy to share the private hospitals also have come forward and joined hands with the government in providing these services to the COVID patients. And because one of the another important thing, I have to appreciate India's pharma industry. India pharma industry is has really come all along, come on the board actually, and they are producing lot of important drugs. At this point of time, we don't have a vaccine, or we don't have any specific drug for this COVID-19. So we have some, if not a specific drug, we have an efficient or reasonably effective drugs in form of a broad spectrum antiviral drug called remdesivir. And remdesivir, I'm happy to say, in up to June, there was only one company that was producing remdesivir. Today, there are about 7 pharmaceutical companies in India, they are producing remdesivir. As a result, cost of one injection, which was costing somewhere around 5,500 in June, now it has dropped to 3,200. This is what is called industry should work on what is called volume cum revenue model. Volume cum revenue model should be the actual motto of all the industries. You sell more pieces, but at a reasonable price. Ultimately, your net revenue will be more. In fact, we at Jaideva Institute also, we are working on a revenue model. We are doing India's highest number of cath lab procedures, angiogram, angioplasty. Daily, we are doing 125 cath lab procedures, which is highest in this country. Last year, we have done close to 40,000 cath lab procedures. As a result, if you are doing 100 cases, easily I can do free. 20 cases I can do free. If I were to be doing only 20 cases, then I would not have been able to do so many cases. So volume cum revenue model is an extremely important. And other drugs are also like HCQ. India is exporting HCQ, and also we have our own domestic stock enough. So pharma industry is doing very well. Imaging also is doing extremely a good job, because there are some new devices coming up, what is called wearable wireless devices, which can monitor these COVID patients, or high risk vulnerable patients can be monitored by various devices. There is a separate topic on that. So again, if somebody asks me how long this COVID-19 pandemic last, very, very difficult to answer. At this point of time, we have only two vaccines, what is called two social vaccines, that is wearing a mask. Mask should be properly worn so that it covers both the mouth and nose. And many people remove the mask while talking. That is exactly at that time only they should wear the mask. And physical distancing of more than 6 feet is the most recommended physical distancing. And these should become part of a culture. Physical distancing and wearing a mask and washing hands should be part of our day-to-day culture, because in Japan, even prior to Corona, physical distancing and hand washing was part of their Japanese culture. So this is how it should go about. And definitely, I think I had taken more than 20 minutes already. And supply chain is another important thing, whether it is drugs, the food. And another important area India has really done well and doing a lot of innovation is in the area of ventilators. So a lot of companies in Mysore itself, in Karnataka, even in Bangalore, they are developed ventilators. So this is how this pandemic and this distress and difficult times have become an opportunity for innovation. And ultimately, at the end of the day, we are concerned. Bottom line is we should be able to provide a cost-effective quality care to the cross section of the society and free treatment in deserving poor. This can happen only when we produce a lot of indigenous product, and this is a fantastic opportunity for all of us. And again, I thank CII and India Innovation for this opportunity, and thank you very much.
Thank you, Dr. Manjunath. I think it was you covered a wide variety of topics. It was very helpful for all of us to get educated on what we've been doing. Just a few questions. Maybe Geetika, if you're also getting questions in the audience, it would be helpful. So you addressed many topics. One of the questions that came to mind was on this fatalities. I think you spoke about 1.3, 1.4% in Karnataka. What are the characteristics that you have observed in such patients where we couldn't save them?
Yeah. Yes, nearly 75 to 80%, 75 to 80% of patients had comorbidities, like they had heart diseases or uncontrolled diabetes or liver diseases. Some of them were dialysis and some stroke patients. So these are some of the comorbidities. Unfortunately, another 20-25% deaths occurred below 45 years of age that did not have comorbidities. So this is one of the worrying factor, because and healthcare workers also suffered a lot. The mortality among the healthcare workers is more compared to the normal non-healthcare group. Probably one of the explanation is healthcare workers are exposed to high viral load because they are working in very high viral load atmospheres. So this is the one of the problem that we had. But definitely 70 to 75% had comorbidities. Another 20-25% did not have comorbidities.
Okay. The second question is around the vaccination. I think you did refer to the vaccinations which are coming up. There is a lot of discussion about the experiments that are going on, trials going on. I'm sure you are more informed and you have a view on which of these vaccines or when are these vaccines likely to be available to the larger public in Karnataka?
Ideally, vaccine takes 1 year. Any new virus comes in, normally for a virus to be, for a vaccine to be available commercially for a public use, it will take 1 year actually. So in our opinion, hopefully we should be able to get vaccine in the beginning of the new year.
Beginning of the new year. Okay.
Yeah.
That's good to know. So I'm getting one of the questions from the participant is on the side effects of post-COVID impact,
Yeah.
and also the issue of recurrence of the condition again after a few months. So these two questions about
Yeah.
post-COVID.
Yeah, just going, probably I did not focus too much on COVID in particular. Before taking up that question, I will just enumerate on the symptoms of COVID also. It's not just fever, cough, or throat pain or breathlessness. These are the textbook descriptions of COVID infection. But other important symptoms of COVID are loss of taste, loss of smell. Morning only couple of people came. I've got just had a body ache, but I'm not. I've lost my smell and taste, and even diarrhea, abdominal pain, and diarrhea is also a symptom of COVID, and my body ache, headache. So sometimes in August, September, a lot of rains and people get drenched. Then they think, no, because I got drenched, I had fever, cough. So you should not ignore in these days. Best is to get tested. That's very important. So the coming to the other question, what is that? Yeah.
Yeah, on the question of post-COVID, one is recurrence and also the other side effects that happen because of COVID.
Yeah. See, COVID is primarily a respiratory disease. That's what it was initially thought. But now, as we have traveled nearly 7 months, the disease is better understood. There is also formation of clot formation inside the arteries, and it's not just simple pneumonia. And within the arteries in the lung, lot of clot formation can develop and resulting in blocking of the circulation in the lungs. That is one. And clot formation, so that is about 85 to 90% of mortality or fatality in COVID, it is due to lung involvement. Another 10% can have involvement of the heart, where it can directly affect the heart muscle, causing myocardial heart damage. It can also rarely cause heart attack, because clot formation can also take place in the arteries of the heart, resulting in heart attack, or it can also develop in the arteries to the brain, resulting in stroke. This is one. Then post-COVID, sometimes those who are critically ill then recovers. There can be a fibrosis within the lung. As a result, there can be a reduction in the functional capacity. Their physical capacity is reduced, because normally lung is like a sponge. So when there is a fibrosis, scarring of the lung, it becomes little rigid. So they will have some shortness of breath even on minimal effort. This is one of the thing. And rarely small percentage can have decrease in the heart function. These are some of the complications a COVID patient can have.
Sir, Ravi here. One of the questions that commonly get asked is the use of home oxygen concentrators. What do you recommend? What's your guidelines on that, sir?
See, oxygen, normally what happens, oxygen should be given to these people when saturation goes below 90, okay?
Okay.
And below 90%. Normal oxygen saturation is somewhere between 96 to 97, normal healthy individual. So normally the admission is recommended when saturation is below 95 or below 94, okay? And home oxygen, but many on home isolation, they have to be careful also. Oxygen is advisable only when saturation goes below 90, and one should be careful when there is a breathing difficulty, when there is fatigue and all, they have to get admitted.
So in that sense, doing your own therapy around oxygen at home is not the best way to go forward, doctor.
But in the acute phase, it is not recommended. In the acute phase, when once they recover, then they go home after recovery. If they have a low oxygen saturation, at that time, home oxygen is recommended.
Okay, sir. The other question that I had is, doctor, we get to see a lot of these SpO2, which are basically finger-based. What's your take on that? How accurate are those, and can they be relied upon for Any assessment?
That's a very good question. Actually, not all the pulse oximeters available are giving a proper reading. So there are some couple of good, makers. They are reliable, and many are not reliable. In fact, on the other day, I came across a pulse oximeter. Your finger is inside the pulse oximeter, but it is reading as his finger is out. So, and when the pencil was kept inside, it was showing a saturation of 80%. So there are fake pulse oximeter. Before buying it, one has to really check. I think one easy cab, that is one reliable. Then another one med, on giant med, something like that. So there are, it's a very good thing, because if somebody has tested positive, if oximeter is showing a wrong reading, that sets in panic, and also that also forces the doctors to give a lot of medicines. So one has to be careful in buying this in buying this pulse oximeter. And always, when you keep the finger inside the pulse oximeter, you have to keep it for at least 30 seconds to sense. Otherwise, sometimes there can be erroneous reading. But I fully agree, not all the pulse oximeter available in the market are good.
And also, the other thing that I have observed, sir, is that when you take a pulse oximeter reading, it starts off with, say, 92, goes up to 95, 96, and then comes back to 92, 93 again. So you see a fluctuation there. It's not standard. It's not steady.
Normally it should be steady. Actually, maybe it can change by 1 or 2 from 99 to 97. But and also it should be it should be well fitting. Also, the finger should be well fitting into the pulse. There should not be any gap. Sometimes if the approximation is not perfect, also it can happen like that.
Okay, sir. Okay. Yeah, I think that's the question. Dr. Manjunath Kukru, over to you, please.
Yeah. Thank you so much. So, Dr. Manjunath, thank you so much for your session. It was very helpful and very interactive and interesting. And I think we have taken a little more time from you than what was planned. Thank you for staying on and helping us with these questions. So we will move on to the next session, with your permission, Dr. Manjunath.
Yeah, go ahead.
And so the next session is on the role of technology. So I think, Geetika, can you make me the presenter if that's okay? I will just share my slides.
Yes, please.
Yeah. And so I know, Dr. Manjunath spoke about how nature is always ahead of humans, and obviously the creator of all of us should be ahead of us. And I'm sure, nature will always find ways of, getting the best of all of us. But as humans, I mean, we have to try our best. And I think over the many centuries and thousands of years, we have managed to kind of live with nature to the best of whatever nature has offered us. So one of the things that humans have obviously used is technology, and evolved technology to manage ourselves and our societies. So in the next maybe less than 8 to 10 minutes, I hope to share a set of technologies that people are using across the world to manage the current COVID situation, particularly the at scale and particularly when you're coming back to some sort of life beyond the lockdown. So the first thing that I would like to share is about how such shocks and such events have kind of created situations for us to evolve new things. Dr. Manjunath also referred to this about how such situations create innovations. So after 9/11 attack, people then started accepting a higher level of surveillance and security checks at most of the places, whether it's an hotel or an airport or everywhere. Right. Similarly, after the SARS outbreak, there was a significant growth in the e-commerce channels. And I'm just giving you illustrative examples, right? I'm sure that tens and tens of things would have changed during such mega events. And obviously, the COVID-19 pandemic has also changed pretty much everything that we knew about. But from an enterprise or a technology perspective, I would like to refer to three dimensions. One is about how the overall customer experience is changing. So we're all used to a certain experience as a customer. That's kind of changing, and we will see how it is changing and what are some of those technologies used to improve those. Similarly, the working is also changing, particularly in services industry, that you will see that the way we work, moving completely away from office and working from homes. This is not necessarily true for example, hospitals or a construction worker, but a whole host of industries are again redefining what how work happens. And thirdly, the social norms and practices. I think Dr. Manjunath referred to this idea of how we are now maintaining social distance, wearing a mask, etc. And there are many more, but I would like to take up these three dimensions and see which technology is kind of enabling one or more of these dimensions. The second part is obviously there are even these phenomena are expected to vary over a period of time depending on the stage of the outbreak. Today we are seeing, or I think maybe in the last few months we saw the primary outbreak during the April, May, June kind of time frame where there were the lockdowns and everybody were kind of extraordinarily conservative, and the way we reacted to the situation was different. And today we are kind of slowly coming back to some sort of normalcy. The lockdowns are kind of toned down. We are kind of trying to get back to work, get back to our learning, living experiences, etc. But then we are still maintaining a different type of restrictions. And we are also seeing there's a whole host of supply chain disruptions that have happened because of the lockdown and related action. And finally, like Dr. said, it may not be over very soon, and there could be recurring incidents. And these recurring incidents could also infuse a new way of doing things, whether it is on the customer side or the working side or the social side. And that could kind of transform the economy, transform the work, the way we deliver our work. It could transform the consumer behavior in terms of what we buy and what we don't buy. Now, having kind of worked and read and studied in this space for a while because of this particular pandemic, what we have also observed is there have been a certain set of technologies which have been leveraged, extensively to manage the current COVID challenge. Here again, an illustrative list. This is not the complete list, but to get an idea to our participants as to what is the role of technology and how it can kind of help us manage this very, very challenging time. If you look at customer experiences, so one of the biggest change that has happened with customer experiences is customers now would want to do things without necessarily interacting with another human being on the other side, because that would kind of, again, chances of increasing exposure. So you would want to do something without interacting with a human. So one of the things that we have seen is the role of autonomous systems, robotics, where today robots are increasingly playing the role of customer service agents, if you imagine. Even I think just yesterday, for I read there is a restaurant, maybe Chennai or Hyderabad, where the restaurant is completely serviced by robots. So there are no people, waiters coming and serving the customers. And now, obviously, that is not the norm. That is not going to happen in every restaurant. But the point is, the technology has that capability, and people are preferring that kind of an environment. So there is a possibility of serving customers with this kind of technologies in our retail outlets, in restaurants, etc. The second example that we could have seen is a whole host of branding and confidence building measures in customers to tell how this particular product has not been meddled with by humans too much in the whole value chain, right? For example, even the pizza making and supplying, where the promise is, the humans have not touched it, and there have been automated machines which have been automating and then, supplying these pizzas. So on and so forth. So the technologies which which can support such automation where human intervention is limited is kind of increasing. The third is this whole host of enhanced digital experiences. So largely, for example, I want to rather do an e-commerce, go to Amazon, Flipkart, and buy something versus going to a big mall. We would kind of sit at home and enjoy a movie rather than go to a cinema hall, assuming whenever it's open. But the point is, this whole shift towards increased digital consumption, which has grown many fold in this particular duration, is a significant phenomena, and whole host of digital technologies are helping, whether it is cloud, mobile-based applications, are helping people still consume their products and services, banking services, for example, right? Using these digital platforms. Now, obviously, there are many more, but the idea is the way consumers experience consumer products and services are likely to change, and technology is playing a big role in it. Similarly, the way employees, workers did their job and how employers managed these employees are likely to change. One of the biggest things is, for example, the security and accessibility. So today, the way we would have access to our facilities, to our infrastructure, has changed today to a largely a remote assessment instead of a physical one, where you have to, for example, go and give your fingerprint to access your office, has been changed to touchless systems, which can, for example, scan your face and then identify and then let you in, right? So these are some of the technologies that are kind of, again, making a difference in our infrastructure facilities of our campuses, of our offices, etc. As you get people back to offices, you still need to maintain the social distances. You still need to see that people are wearing masks, etc. How do we do it in at this large scale without necessarily having a policing team, right? So here is where all of this computer vision technologies, using videos, which are like security camera videos, using those videos to be able to assess if people are maintaining social distance, are kind of following the masking rules, etc., can be easily evaluated and alerted, etc. The third one is one of the biggest transformations that has happened, which is about the collaboration tools. Providing collaboration tools and collaboration capability, infrastructure for thousands and thousands of workers who can work remotely in a very short period of time, I think has been an amazing turnaround that large companies have been able to achieve, particularly services companies here again, with which the whole impact on the way we work, the role that people play in the future, the infrastructure required for companies to play these roles, etc., is likely to change. And the final dimension is on the social practices. So on the social practices, the example that I would like to quote are all this contact tracing and early detection. How can we help the larger society, larger population be self-aware that if they're infected, how do they know that they're infected, and how can they make sure that people in their network and people in the society in general can manage to avoid getting infected with other infected persons. So this whole contact tracing kind of technology, like the Arogya Setu apps, is playing a big role. And here again, the hidden technologies of data privacy technology, which kind of help to protect the privacy of our individual citizens while still providing such intelligent information to our customer, to all individuals, is a big capability. The other set of technologies I would like to refer to are the 5G, the AR, VR kind of technologies, which are in the process of transforming how we consume sporting and entertainment, and even telemedicine in the current context, because these technologies are going to give immersive capabilities for people to do a remote therapy, remote assessment of people, and obviously enjoy the games and entertainment. And finally, the social infrastructure that our governments will have to put in, like whether it's the financial infrastructure, like the payments infrastructure that we have today. And I think we're going to talk about the healthcare infrastructure, which will provide for remote confident and reliable services to large number of customers, large number of patients and individuals, both for health and wellness on a considerable, consistent basis over a period of time, will make a big difference. So I think there are a whole host of these technologies which are making a big difference. I'm just looking at my clock. Maybe I'll just take 30 seconds. So if I have to summarize, many of these technologies focused on, let us say, healthcare, as in hospitals only, or kind of hospitals related technologies. The key evolving themes that we see are, for example, virtual physician visits. A whole host of, like, for example, I have not taken my parents to their doctors now in so many months. I do an virtual review with them. And this also is going to lead to digital marketplaces where you will have a lot of doctors, a lot of hospitals, coming together to service different patients, which was not the case before. A lot of integration with emergency kind of situations with the rest of the hospital network, supplier networks, etc. And also this whole idea of how do we test this healthcare infrastructure for, I hope no more pandemics would happen in the near future, but how do we get ready for such situations? Not by building more hospitals beyond a certain capacity, but even the current infrastructure, how can they be used? How can we simulate and then study where are the gaps, and so on and so forth. And obviously the telemedicine is, I think, the biggest change that has happened in the healthcare world, from a technology come customer experience impact, because of this COVID situation, where more and more patients are going to get treated from their homes remotely through doctors and hospitals, etc. And there are a lot of good examples of this happening around the world, and I think India will also see a lot more of these. And the supporting technologies obviously cut across the whole host of technology that I spoke about, whether it is AI, whether it is IoT, cybersecurity, and mobile healthcare, etc. But broadly, I think this set of technologies will help make a big difference to our healthcare in the near future. I'll kind of pause and see if I have to take any questions. I'll be happy to answer any questions.
First of all, Manjunath, I would like to say thanks to you for having expounded it so beautifully and so succinctly.
Thank you, thank you, Ravi sir. Thank you. Any questions? Been a while since we met. Okay, so if there are no questions, I think anyway we are kind of running a little late. So we can have our COVID survivor share his experiences. So Ravi sir, can you introduce the next speaker?
Yeah, I think we have got Mr. Ramachandran here with us. Thank you, Mr. Ramachandran, for joining with us and sort of trying and helping us share your experiences of what actually you have gone through, because it's going to sort of be very, very, shall I say, motivating for us to hear from you what has actually transpired, because you require that emotional and mental strength to go over such pandemics. Over to you, Mr. Ramachandran, for sharing your experiences with us.
Thank you, Ravi. Can you hear me? First of all, let me do a system check.
Yeah.
Okay, fine. So I am going to, first of all, thanks are on audit for CII to allow me to speak and share my experience. I, with your indulgence and your permission, want to go on off the video because I don't want to frighten too many people. I am currently on oxygen supply just for a few minutes so that it doesn't go out. So I'm going to seek your permission to stop my video and I will address you over the audio. Is that okay?
Thank you so much for having started off with the video, sir. Much appreciated. Do what is convenient.
Thank you very much, Ravi.
Pleasure, sir.
So my story starts on Friday, 3rd July. It was about 5 p.m. and I was in my house Bangalore was a little bit chilly. It was cold. So I was feeling whether it was cold, I was feeling cold, or uh, whether the Bangalore climate made me feel cold. So I asked my wife. I said, see, touch me and see whether I'm running a temperature. And touched me, and then she put a thermometer in my mouth and said, "Yeah, you're running 99.8." So and I said, "Okay, fine. It's a small temperature which is mild. I can go without any medication." Went without any medication for that day, but the next day, morning itself, the temperature rose to 100.9. And by Sunday, which was the 5th, I had a temperature of about 101, 102. My wife panicked, got a lot of ice packs and all that, put it on my head, put it on my groin, everything. She did, but temperature didn't come down. So we drove to Sagar Hospital, where they examined me for the sudden temperature. And they had to also test me for COVID-19, which was mandated by BBMP during that time. Little did I realize the harrowing experience for the next 2 months that I was about to embark on. On Monday, which was on the 6th, I got a call from BBMP stating that I have tested positive. And since you are above 60 years of age and you have comorbidities like BP and are also mildly diabetic, you have to get yourself hospitalized. And I said, why can't I do the quarantine from home? They said, no, this is comorbidity, you're above age 60, and BBMP operates with a checklist. So they know what is a mild attack, they know what is a moderate attack and what is a severe attack. So my case was a typical case of a mild attack, but that had to be hospitalized. So what I did was I said, look, which hospital am I going to? BBMC said, they don't know, but the ambulance will know. The ambulance will pick you up in the next 5 hours. So I said, okay, fine, I'll wait, but is it going to be a government hospital, private hospital? They said, no, it will be a government hospital, most probably Victoria Hospital. I said, no, I would rather like to get admitted to a private approved hospital. By that time, BBMP also had a list of their own private approved hospitals. So hospitals like Manipal, Apollo, Fortis, all these had come into that list because they simply had to have the bed capacity. So these private hospitals had also come into the play. On Monday evening, my wife drove me to Manipal Hospital on Airport Road, where they said, you come over, we'll test you, we will find a bed for you. This was after dialing up many, many, many hospitals in Bangalore. We had to use a lot of influence, known doctors, circles, etc., to even be called by Manipal Hospital. On Tuesday, July 7th, I got myself admitted into the Manipal Hospital. Initially, the story was that I'm going to be there the next 4 days, will be treated within the 5 days, and I'll be discharged. So I was admitted to a ward, was there for 4 days, and on the 5th day morning, I had an emergency in terms of the oxygen level going down below the danger level. I think Dr. Manjunath talked about 90 was the lowest threshold. I think mine must have dropped to about 60. So before I could say Jack Robinson, there was a cylinder that was put on my bed, and my bed itself became very mobile. And they wheeled me into the ICU. The first 4 days, the doctors came and told me that all the numbers were looking good. were going in the right direction, and they were thinking that they could discharge me soon. And therefore, the fifth day morning events took me totally by surprise, and I was in a panic mode. And remember, in ICU, you are not allowed any phone calls, no phone calls are allowed, network is not there. Only the doctor's phones or the nurse's phone work. And if you got to be in touch with your family, you got to borrow the phone, the doctor. The real ordeal for me as a person started in the ICU. ICU, you are there for the minimum number of days. So hospitals usually charge a premium for being admitted to the ICU. So therefore, they also want a quick turnaround. But they won't keep you there unless it is absolutely necessary. And I was there for 10 days. Out of my 30 days in hospital, Manipal Hospital, 1/3 of that was spent in the ICU. And that is where it gets you emotionally and mentally. Because there's nothing much to do in the ICU rather than just lying in bed. You can't get out of bed. Being witness to other patients like me in the ICU, which had 19 beds, was an experience that I will not want even my worst enemy to undergo. Somehow, magically, during those 10 days, my brain felt as it was tossed into a washing machine to be rolled, tossed up and down, and then dried out. So while I was mentally alert, I was and also at times when you can't get any sleep when you're in ICU. Hello, can you hear me? Can you all hear me?
Sir.
Yeah, okay. And on many days there were deaths and bodies were wheeled out of the ICU to the mortuary. So out of a 19-bed ward, if you have on some days 2 people dying, 3 people dying, on some days I witnessed about 5. That was the maximum. You really wonder whether you're going to be walked out of the ICU or you're going to be wheeled out of the ICU. And the strange thing is that when there is death that occurs in the ICU, the doctors in charge, all the nurses, and all the ward boys who are there go around, around the body and embalm it. Because as per government rules, they cannot just discharge the body back to the family. The family, in fact, does not get to see the body at all. It is embalmed, it is put in an aluminium sort of case, and then when it is wheeled out, the family sort of peeps into that small window, peephole, to see the face of the body. And that is a nerve-wracking experience because when in the ICU, most of the people who are there, and that is a very depleted staff, they are surrounding the body, embalming the body, making sure that the body is completely embalmed and ready for disposal. You find that all of them are attending to the dead rather than to the living who are watching this. So next day morning, I complained to the ICU doctor in charge. I said, "What is happening, doc? There are so many deaths here, and you people are spending more time with the dead than with the living. It's not giving us any hope. I mean, am I being neglected? No, 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 no. What I think I fail to understand, I will come to my learnings later on, that these doctors and the nurses and the ward boys are all overworked. They're working 12-hour shifts and they've got to complete certain things within certain time frame so that they can go back and after 7 days or quarantine period, they can come back to work. I really do not know what really motivates these young people to come back to work and to serve others. Really hats off to them. The strange thing is when there is death that occurs, all the staff of the ICU gather around the body and start embalming it as per the rules of the government. And this, when you are sitting in the ICU wide awake day and night, you can see the governance structure in place, how everybody knows what role they have to play and what role they're actually playing, how they're ensuring that they are keeping a tab of all the 19 patients in the ward. And even if I have to just even squeak, saying I want water to wet my lips, there is always a nurse that comes around from what she was doing to hand over cotton waste dipped in water so that I am able to get that water that I want. The doctors who are assigned to keep you, who are assigned to you, keep visiting you in the morning around 10 a.m. to 12 noon. They're always positive. Give you an update as to when you're likely to be discharged out of the ICU. Not out of the hospital, but out of the ICU. And then you eagerly await for the day. Meanwhile, all the medicines are administered to you through your veins, and you have a needle poke marks all over your arms and legs. It is quite painful. I'm going to quickly go down to the lessons learned by me. I think, what are the lessons I learned? I have to take even a mild temperature. I had no other symptoms. I had no sore throat. I had no cough. I had no chills. A mild temperature, seriously. If hospitalized, make sure you trust the doctors to do their best. I am a diabetic patient and a BP patient, so I had comorbidities. And therefore, I take, the diabetic tablets in the morning. In the hospital, knowing that I was a diabetic, turned my tablet into insulin. And I said, insulin? Why would I want an injection when I got tablets to swallow? But the doctors do that for your best interest because they want in this treatment for COVID-19, your insulin level varies quite a bit. Whereas in a tablet, the dosage is fixed. In insulin, they can give it you by units. So in some days I got 2 units, some days I got 8 units, some days when my level was very high, they didn't give me insulin at all. So trust the doctors to do their best and do not question. All the doctors in all the hospitals are overworked and have taken a grave risk to themselves despite they are wearing their PPEs and full gear. Sometimes I used to wonder, why is the doctor not giving me enough time? He comes to me, talks to me, and by the time I am ready to ask him a question, he's gone. But then you understand that he has got 18 other patients to look at. And most of the doctors are doing 12-hour shifts, not an easy one. While I consider myself emotionally stable and strong, do not underestimate the environment in which we find ourselves, in whether we are in hospital or especially in ICU. Even the strongest can have shivering in the limbs. I believe personally that more than medically and clinically, because that is taken care of by the doctors, More attention has to be given to the mental health of the long haulers. Long haulers are those who are in a hospital for unduly long period of time, which is, I think, would extend more than 15 days or 18 days. Irrespective of how positive one is, you are bound to get into a negative frame of mind with a flip of thinking. There is nothing else to do in a hospital bed. Discharge from hospital does not mean that the recovery is complete. This is the most important thing. I am still on oxygen because sometimes in the night the oxygen level drops, but it does not drop to that dangerous low levels. As I think Dr. Manjunath mentioned, if you're in the house, if it drops from 90 to 88, 85, 86, does not matter. But if it drops to the 60s and 50s and 40s, that's when your brain starts getting affected. That's the first organ in your body that gets affected. And being a professor and a lecturer in some colleges in Bangalore, I really don't want that to happen. It takes another 3 to 6 months after the discharge for one to be completely recover. In other words, what we are thinking of is a rehabilitation rather than just recovery. The pandemic and the disease has already left me. I am already COVID-19 negative. I've already tested that. But one is more important than that is you never know. As researchers said, again, as Dr. Manjunath said, we really do not know whether it will attack you again, whether relapse will be there or not. What have you got to be doing to keep yourself, uh, make sure that you don't relapse into another COVID-19 attack? And therefore, that means keeping your body strong, keeping your lungs, making your lungs even more stronger, because this disease attacks the lungs and the respiratory system. And therefore, I am also on what is called the physiotherapy and aerobic exercise. It's going to take at least another a month, 2 months. Some doctors say, well, nothing is going to happen in the world till December 31st. Everybody is going to be on remote. Businesses are going to do their businesses remotely. So you take a rest at home. Don't stir out of your home at least till end of December. If you want to travel and do a test travel, it is only going to be next year, not this year. So that has been my experience and my learnings. I think I've taken the time, which is a little bit of a premium. 15 minutes was allotted to me, and I thought I will keep and share my experience with all of you. If you have any questions and all that, I think if you pass it on to the organizers of this event, I'll be happy to share them with you. Thank you very much, Ravi, and thank you very much, CII, for giving me this opportunity.
First of all, thank you so much, Mr. Ramachandran, that you could come and sort of talk to us about your personal experience. I know it's so personal, it becomes quite a challenge sort of sharing it in an open forum like this. But then our sincere thanks to you, both from at a personal level as also on behalf of the CII, that you could take this time off and spend some time with us. Sincerely appreciate this, sir.
Thank you, sir. Thank you very much indeed.
Thank you very much, sir. Thanks a lot. Over to you, Julian.
Thank you so much, sir, for the wonderful experience and the discussions led for. I now request Dr. Vikram Venkateshwaran to lead the session on decentralizing healthcare, the role of PHC, CHC, and tertiary hospital. Over to you, sir.
Thank you very much, and a very warm good evening to everyone. I think what we heard just now was a remarkable story. And it's a story of grit and determination. But imagine a city dweller in Bangalore having to go through all this. Imagine the plight of somebody in a rural area, right? We don't even want to start thinking what they go through every day. I think just setting the context for today's session, it gives me a lot of pleasure to invite, our fellow panelists. And obviously, all of you know Ravi Ramaswamy here. He's been the heart and soul of healthcare for a very long time, at least when it comes to digital transformation, innovation. No discussion can be complete without Ravi being there. Ravi, thank you for being here.
Thank you, sir.
Also, I briefly saw Arvind Sivaramakrishnan, CIO Apollo Hospitals. I know he's a very, very busy man. So I promised him that we will make his time worthwhile. So thank you for joining in, Arvind. Also want to welcome Dr. Ashwin Nayak, who's, I think I saw him briefly. I think he's here. And Ashwin, obviously busy with, was a former CEO, founded Vatsalya Healthcare, now a co-founder with Mana Health, an activist, has done a lot of work at the grassroots level. Will be very, very interesting to get your views as well, Ashwin. And last but not the least, I want to also welcome Girish from GE Healthcare. Welcome to the session, Girish, and looking forward to hearing your views as well. So with that in mind, I have a very simple format. We're going to talk about decentralization, but also talk about the role of the PHCs and the CHCs and how we can use them to improve tertiary care, right? Just for the audience, when I say CHC and PHC, I mean the community health centers and the primary health centers, which are the backbone of healthcare infrastructure in India. 70 to 80% of India depends on these centers. So with that in mind, let me straight away get into the topic. And Arvind, if you don't mind, we'll use you as the opening batsman. Virender Sehwag or however you want to picture yourself, maybe Shikhar Dhawan now or Rohit Sharma. So Arvind, if you recall, some time ago, you and me were at a conference, probably it was in Delhi or somewhere, where we started talking about referrals and the flow of referrals that happens from districts and the CHCs and PHCs. And you operate a lot of hospitals in some of the tier 2, tier 3 towns. For example, you have a very nice hospital in Kochi. So what do you think, is the challenge today that these referrals become a hindrance? The flow is not as simple as it looks like. So what needs to be done to kind of empower the CHCs and PHCs to ensure that the referral flow to a larger hospital, whether it's a district hospital or even to a private hospital, is facilitated? So what are your views on that?
Thank you, Vikram. Good evening, everybody. See, when you look at what is it that is, preventing or inhibiting this whole referral process, I think it's the ambiguity of what happens. And it's also the ambiguity of, and like what Mr. Ramachandran was mentioning in terms of, everybody knowing what they're supposed to be doing. I think those are first and foremost, which are not very clear. So it's not unfair for me to say that it does not create an atmosphere of trust. And when that is there, and this is primarily because now let's go take it as I don't want to get into subjective thoughts like this, but what is going to make this work in terms of a referral network and all of that is ensuring that there is accountability to outcomes, and those accountability to outcomes are well measured and well published as per guidelines. And that holds good for all aspects of it, whether it is operational, patient quality, patient safety, clinical outcomes, clinical efficacy, including the empathy and the service experience of people. So when you do that, you start looking at in terms of, and as all of us would look like, hey, I want to go to a nice place. I want to send you to a nice place. I want to send you to a safe place. And these are words that all of us have lots of definitions around. So, this, when it is governed by a well organized structure, you will see that whether it is a tertiary hospital in a metro city with much more infrastructural capabilities, and thereby the logical talent that goes with it, with a large city, or it is going to be a gram or a panchayat level public health center, the whole process will be seamless. And here again, building that whole culture of internal medicine or general medicine being the starting point, and using the specialists. And the specialist can be in a tier 2, tier 3, which tier 1, whichever location, but not consuming the specialist when the generalist can easily handle them effectively. When I say easily handle them, I'm talking about, again, good clinical effectiveness measured by quality. So it's not about depleting care. I think all of this, when you put together, is when you will see the referral models being effective. And above all, ensuring, and it is essential that you have the care record pristine. Thereby, when the longitudinal record is pristine, the follow-up of care across the various centers is done in the effective manner, thereby also ensuring cost, quality, all of them are well preserved and well accounted for. I think all of this has to come together when you see this entire referral model, singing in harmony. Otherwise, we're going to have a disjoint system, and you're going to have your suspicions cast on every point of delivery. Sometimes there may be truth to the suspicion, and sometimes it could be our own inferences that we would draw. I think that's really what is required to get everything done right, and tremendous amount of discipline and transparency in care.
Lovely, Arvind. I love the way you said symphony, a symphony of trust, if you may summarize your statement. But, there was one statement that I always used to hear, that you have a small nick in your knee and you want to see the HOD, right? You don't want to even show to the duty doctor, you want to go to the HO department.
And knowing our systems, if you go a little further, I'll say, do you know who I am? And go and tell him. So you've got to start having that whole done. It breaks the system.
Correct. So coming to you, Ravi, Arvind brings up a very good point. There is no longitudinal record. Forget about clean longitudinal record. We don't even have a longitudinal record. And I saw that the National Digital Health Policy was released with a lot of fanfare. We've had the health stack, which iSpirit and others have been working on for a while. Do you think that is going to make a difference? Because clearly, if I don't know what I'm treating, I can't treat you.
I think absolutely, doctor, in the sense that I articulated it as neatly as what Arvind mentioned. Okay. When you're talking of longitudinal record, when you're talking of patient management, it is absolutely imperative that you know what are the interventions what is the diagnosis for the patient, what did he come in from, what was the diagnosis, what were the interventions, what were the outcomes, and then again going back to the next intervention, more so if it is a chronic case. Now, if you really look at the healthcare system today, it is completely broken. Each hospital, each unit does not really have an IT of sorts that as an expense, not as a revenue model, not as a asset in that sense. So each hospital, barring the big ones, they hardly have anything worth the name that you can call as an EMR, wherein the patient's records are translated. Even when I have to move from one hospital to the other, I have to carry a folder of prescriptions that I need to go and show to the doctor, which he keeps flipping around. Now, given that, I think that is on one side of the story. I don't want to actually go and paint a negative picture into the forward. If I were to fast forward for the next 5 to 10 years, I see something very, very different coming up there. You look at the way that digitization has transformed India. You look at, say, telecom, the way that you are able. I used to have times in Larsen and Toubro when I used to wait for a trunk call for the US because STD facilities were not available then. But as against that, you're now able to pick up a mobile phone and make a call anywhere in the world. Okay, what used to take 5 years to get a telecom line, you're now able to get it in 15 minutes. Look at the time when I made my first trip to Japan. I used to carry traveler's checks with me. Today, travelers' checks are a thing of the past. You have got debit cards, credit cards, what have you, electronic modes of fund transfer. So if I draw a parallel from the telecom industry and from the financial industry, there is so much of digitization and the transformation that has actually gone in, which can make significant difference to the way that we work and the way that we live. Healthcare is not going to be far behind. My hope is that healthcare is going to leapfrog based on the learnings from the telecom and the financial industry. And the National Digital Blue, coupled with the 12th 5-year plan and the health stack, the wonderful work that is being done by Sharat Sharma and his team in iSpirit, I think that is going to provide us the entire backbone of plumbing that is required to sort of move data around, bringing in a certain amount of interoperability. Once that come in and people realize, I believe there is a system of records that is being built. Once that happens, you know for sure saying that the data is going to be captured, and with the way that the DigiLocker is being used, we would be having a similar set of capabilities based on which your data, your medical data could also be sort of stored and retrieved at will. Of course, with the right consent, with the right privacy levels and stuff like that. So in the future, when I'm really looking at it, I think there is enough and more merit to say that we can look and derive the learnings out of the telecom and the financial industry to come up with a solution for the healthcare by which we are able to sort of solve the longitudinal record problem in a meaningful way, and thereby hit what Arvind talked about as the quadruple aim, which is basically looking at patient satisfaction, looking at enhancing sort of driving down the cost of care, thereby making more care more affordable, even at a decentralized level. I think that's where I would like to summarize, and I am an optimist as far as this is concerned.
Good to hear that. Because it's always, when you talk about healthcare, it's all doom and gloom.
But I think we have to look at it differently.
Agreed, sir. So, okay, I mean, I agree to an extent, right? That we have a lot to learn from banking and how they've standardized things, and with telecom, because telecom is a big story for us. But let me put Ashwin on the spot, because he's worked a lot at the grassroots level. If you call Ravi, if you call this system broken system, Ashwin, I'll call the fixer of broken systems. He's done it in the past with Vatsalya, and now he's doing it in a very critical area, right? Which is mental health with Mana Wellness. And I had the opportunity to share some screen time with him also sometime earlier, just as the lockdown started. Little did I know that I'll still be in lockdown after 6 months. So Ashwin, just getting a sense from you, you see this happening. You've seen this happen in the past as well. How do you see this scenario playing itself out? We have a referral issue, while we have a standards and blueprint and everything come up, but there's nothing fixing the two. So how difficult or how easy is it to fix this system?
Thank you, Dr. Vikram. So just going back to your remarks, we met during the start of the pandemic, and we just discussed what is the mental health impact of this, hoping that this will be about 3 or 4 weeks. And here we are 5 to 6 months later. Just a parallel to that, the Indian primary health model was devised in 1945. It's a beautiful model. It's a Bohr committee report. It has laid out in extreme detail how this primary care model in India will work, how it will connect to the tertiary care, or the entire piece. And here we are again talking about primary care. So I think, I feel like the real problem is not creating the framework, creating the documentation, but getting into the implementation, getting to create the right incentive. And what are the incentives from a patient's perspective or from a person who's affected his perspective, going back to what Mr. Ramchandran was saying, what are individuals and families actually seeking from the healthcare system? I think Arvind ji touched upon it, Ravi ji touched upon it. The first thing is we all want information, right? We want to know what is happening to me. That basic piece is missing today, right? We are being shunted from place to place, and all these artificial differentiation of primary, secondary, tertiary, quaternary. I don't care as a customer. I don't care, right? I'm here to get something out of this system. So this artificial system is not helping me. So how do we make sure information is available when I need it? Right? I think that's going to be the significant push. And this goes back to Ravi's point about how technology will make that more accessible. We don't have to rely only on the doctors, only on the hospitals to get this information. I think we'll have a new model. At least the primary care will look very different from what it is today. The second one is, again, going back to Mr. Ramchandran's point, is time. I don't think we get the time and the hearing with the doctors, right? So which means that we are not going to quadruple or significantly impact the number of doctors we have. So the only way we can increase time is by upskilling people to do much more than what we are doing. Nurse practitioners, physician assistants who can do 80% of what is happening in the hospitals, in the rural setting, at least in the primary care setting, is what we need, right? The anecdote that you mentioned of going to the heart surgeon for a common cold is real. I mean, it's not a joke, right? I mean, everybody wants to see the big boss in the hospital. So how can we upskill people so we can take care of primary and secondary care? The last piece, I think, which is in a way greatly impacted adversely during this COVID period, is respect for the profession, right? I mean, look at the state of doctors. On one hand, they are dying off of COVID. On the other side, they're being beaten up. I think there needs to be a significant rebuilding of respect, and that will come from rebuilding of trust. The institutions are broken, the systems are broken, and there's a general mistrust. So unless we put these fundamental pieces of information, time, trust, etc. in place, I think it's going to be very, very uphill task. I'll end with two other points. I think these came up during our discussion. One is the importance of mental health, right? And mental health is no longer a standalone subject. Mental health is, in a way, health, right? It's an integral part of health. It's an integral part of primary health. So how do we build that into everything that we do? And the last piece that I want to highlight is the role of community, the role of community in keeping you healthy, right? I think if you put too much emphasis on the formal healthcare system, we'll only go maybe 10, 20, 30% of the way. We know from our experience and from research that healthcare is about 4/5 is social determinants and 1/5 is hospital care. So why invest everything in the hospital care and leave out 4/5 of it? So making sure the community is involved as much as possible, mental health is prominent, and we look at what is in there for the individual and the patient, I would say would be the key points.
Thank you, Ashwin. Talking to you always gives me new ideas. So we will probably connect after this. But I think you bring an important point. The way I look at it, there are various components to one's health: mental health, physical health, nutrition, your family circle, your social welfare, your maybe sanitation, etc. So I think from what you are trying to say and what Arvind said in the beginning and what Ravi alluded to also, there seems to be a coming together of various factors that will help this. It can't be just if Arvind and Apollo Hospital's problem that this has to run. It is also your family's problem, it's your locality's problem, and it's also your nutrition and health, etc. Backed by a very strong technology backbone. So I just want to get in Girish here and get his perspective. Do we have the ecosystem in place to do this? Does the ecosystem even know that they have to do this, right? And what is his views and what has he seen as part of his experience with GE?
Yeah, sure, Vikram. I think I would probably build upon what Ravi was explaining sometime a few minutes back. See, I think from an ecosystem play perspective, I would believe we have two primary things which are going to define. One is the standardization of data, right, and the information flow across the system upward and downward, right? What Ravi was explaining. I think that becomes a very important element of the ecosystem play. If you look at in today's context, do we have it? Answer is no. We have bits and pieces here and there. But the good news is the National Digital Health Mission is going to provide a framework and perhaps a broader ecosystem into which whatever we are going to do in the years ahead would fall into. So I think the ecosystem would predominantly evolve around the National Digital Health Mission. But we do have a lot of challenges today, right? The challenges today, I would say, are one in ensuring both quality of data through proper standardization and also the quantity of data that will be more comprehensive with minimal variability as it flows across the health system, right? If you go to a tier 2 or tier 3 cities, the quality of data, when it goes up to the tertiary care system, right? How credible is it? Right? How much do they value? How the systems we have in the PHCs and CHCs, are they advanced enough that the tertiary care doctors could take the data at the right spirit and act upon it? So I think that becomes definitely a big challenge we are going to see today. So the data flow and the quality of data would definitely make a big impact. The second point I would believe, data security and privacy. There are a lot of concerns which we hear today, right, about as we build this information highway of data flowing across up and down and left and right. How do we ensure the data is secure, privacy, and the privacy is maintained? And I think the Aadhaar has actually brought in I would say, kind of framework on which we can build up. But definitely, that is a big perspective what people would have. And lastly, from a challenge perspective, I believe we should definitely onboard more startups effectively, because the startups can effectively complement the gaps we have in the ecosystem. If you look at the whole system, we have a lot of gaps. There are areas where there are big companies playing. There are gaps where nobody's playing today. There are a lot of missing links in the whole system, right? And given the fact that 16% of the startups globally are in India, it is very encouraging, right? Now the question would become, how can we encourage these startups to come on board, and how can we, as a community, provide a conducive environment where these people can come on board and effectively fill the gaps, right? So I think if we can get data part of it taken care completely well, and if we're able to put together an ecosystem where the startups can come and fill the gaps together, the ecosystem would be much more broad-based and much more comprehensive, and it would be a good step towards ensuring we hit the mission what we have in front of us, Vikram.
Thanks, Girish. Thanks. I mean, I did not realize that 16% of all startups were in India. I know we have a lot of startups in Bangalore, but that's a number is mind-numbing. So, no, all the reason to feel very enthusiastic about the scene. And thank you for sharing that. But I just want to take the discussion further, right? So, if we are saying that, the system is broken, and if I say that I need a way to fix it, and there are gaps, and we can learn from what telecom has done, what the financial services system has done. Then is there a reason to rewrite the entire process or the SOP? Like Ashwin is saying that I don't need primary, secondary, tertiary, and quaternary care. That doesn't matter to me. That's an internal classification for you. Why impose it on me? So would like to bring in Arvind here, because he's the closest to how the healthcare system, the rules at least, and how the regulations work today. So Arvind, is it possible to rewrite this entire thing? And how do you think that will work out if we attempt to do that?
Vikram, the way I would say this is, it's not about rewriting or something. All along in healthcare, the only thing we should be doing, whether we are doing it now or we were doing it, whatever it is, we should be working towards outcomes. So work processes that are going towards good, effective, desirable clinical outcomes is what the health system wants. And very correctly, as what Ashwin was mentioning, it's not about compartmentalization or silos of primary, then you move to secondary, then you move to tertiary. No, this is about speed to diagnosis and effective care protocols that get into your course of wellness. So getting well from the diagnosis that is there, So it is about that. It is about getting it done fast. So you have to do it in terms of drive towards outcomes and not drive towards conveniences of operational processes. So, and this is common in all the aspects, that we design it to suit the processes of the provider. We have to suit the processes of the care that needs to be offered. So don't think it's disruptive thinking or anything in that standpoint, or rewriting. I think we need to be cognizant of that. And with what healthcare is suffering, and again, like what he mentioned in terms of it can be done with physician assistants and all of those. See, you'll have to employ the right resources in the right place. So that means you're optimizing it. And healthcare today is definitely short of knowledge workers in the field of healthcare. We're always short of it. So that augmented with technology that ensures that there is level of consistency and surety around the care, so that the already short workforce can be made more effective. I think that is there. So you're designing for a workflow. You're designing for an outcome. You're not designing for suiting organizational conveniences, irrespective of the care process. So I think those are aspects that we need to think of and reimagine. And that is definitely something where we can look at several areas of other industries, how the retail industry benefited from some of the e-commerce, how that was done from the traditional world to the e-commerce world, how you're looking at even the hotel industry changing as it relates to booking and all these, the OYOs and all of those that are there. So I think you're looking at such processes. And again, go back to the traditional Motorola Six Sigma processes, always a learning for everybody there in terms of how things can be done and how things can be changed. I think we'll have to learn from all of those. Learn from the manufacturing sector, where there was the assembly line and the moving assembly line, and you start. So what did we do there? We designed two outcomes. You need to get this particular manufacturing element fast. And you know what? I'm comparing healthcare to manufacturing, but that's not always improper to do. It's a learning that you're looking at it. I think that when you do, automatically SOPs will start becoming what they need to be: optimized, focused on efficiency, constant metrics to monitor whether you are keeping in line. And when you start seeing aberrations there, you clearly know that your SOPs need to be revised, or your operationalization of the SOP needs to be done. One of the two has to happen. I think that is when you start looking at it. I don't think it should be looked at from a textbook manner or a desirable manner. No, it should not be looked at from in those viewpoints. So I would say, think of it this way. Do what's right and frequently change if required based on measured outcomes. That's really how we should be looking at SOPs.
So designing for outcomes, Arvind, this section.
Absolutely.
Brilliant. So let me take that discussion forward then. So one of the big things that happened in COVID, and Ravi and even you and me, Arvind, we've talked a lot about it, is telemedicine. Right? Finally, we have an answer after 15 years. Yes, no, legal, illegal. And I know a lot of hospitals, including Apollo, their telemedicine consultations have gone through the roof. Probably one of the few hospitals that already had a system in place, right, for a very long time. So, Ravi, the question is for you, and I'm going to follow it up with a question to Ashwin, because I think, in my opinion, telemedicine has big impact in the area he's working. So, Ravi, you think telemedicine is that designing for outcomes? What Arvind is talking about, is telemedicine an answer to that?
Yeah, I think let me sort of step back a bit and give you an example that happened in the company itself. At one point in time, we were running short of space, and I came to my boys and I told them, saying, guys, I need 20% space, in the sense that if you are having 100 people, I'll give you seats for 80. The 20 you manage out of working from home. And people came down on me like a ton of bricks, saying, "Are you insane? Do you even understand what you're talking about?" And today, I have 5,000 people in PIC working from home and with the same amount of productivity and effectiveness. So, what I'm saying is to draw an analogy, because we always had this misconception that telemedicine will not work. And I think nature forces you to do things which you have never ever done in the past. And we saw what Mr. Ramchandran also alluded to. So, in that sense, the touch and feel, like for example, when I was small, I used to go to a doctor, a general practitioner, MBBS, and he would sort of feel me, touch me, look at my eyes, open my throat, do all sort of diagnosis, and he would give me a prescription and a medication, and which worked. I have survived so long. But at the same time, today when you go to a consult, relying on the test part of it than the physical touch. Now, if that is going to be the case, then why is it that telemedicine is, why do we even feel that telemedicine is not going to work? And given the pandemic situation that we have today, I think that's possibly one of the best and the most safest alternatives that people, that even adversaries who would never want telemedicine are now recommending telemedicine. And in doing so, you get multiple advantages there. For example, you are able to sort of share the talent across the network and reach out to places where the talent was simply not available in the earlier case when you had to do it physically. And secondly, you're also driving down the cost of care significantly, because it is not only the fees that you pay to the hospital for a consultation, it's also the total cost when you look into the transportation, the time that you spend in transportation, the other family members that come along with you. So when you look at it from a different perspective, you're looking at the total cost of care, and that is something which is going to go down significantly with telemedicine come in. Now, where do I see the hiccups there? We find that today we have got enough and more telemedicine, and even where I go for, I'm doing telemedicine. Telemedicine in their own small pockets. You do not have a single player who spans across the continuum of care, saying, "Guys, I can offer you everything. You come to me, and it is as good as going to a physician, and I will be able to diagnose and give you the prescription and give you the treatment which will cure you." That sort of assurance is simply not there. Yeah, I go to somebody who says I practice diabetology. I go to somebody who says I'll take care of cardiology. I'll take care of rheumatics, what have you. But then that silo has to be broken, and at some point in time, we need to come together as an organization to ensure that we are a lot more broad-based, a lot more united, rather than having all these fractional guys out there and not really meeting the end purpose. Then what happens is data interoperability and portability also becomes a huge challenge. So in that sense, I appreciate Chris and the SWAST team in terms of what they're trying to do in bringing in a sort of a connectivity at a national level. I think we need to do something radically different to ensure that telemedicine succeeds, because to me, that is the only answer that we have for the future.
Thank you, Ravi. I think you are right. And till the silos don't get broken, we can't take a modern concept like telemedicine and again put it into the silos that we have created for a SOP that was built for our convenience, and for a system that doesn't look at outcomes but just looks at meeting the hierarchy of what already existed.
Very true.
So let me take that discussion forward. All throughout, whenever I used to look at telemedicine, I used to think the biggest beneficiary was to mental health in India, especially because of purely societal reasons, right? Because mental health was such a big taboo topic. You don't want to be seen going to a counselor or taking a second opinion. Um, Ashwin, I'm kind of putting you on the spot because I know we discussed this in the past as well. But now that telemedicine is 6 months in officially, do you see the impact on mental health? And if you see the impact on mental health and the consultations, do you think this is the beginning of fixing of the broken system?
Well, yes, I think this will be a big catalyst for sure. Whether this will fix the challenges associated with mental health, I think there is some way to go there. But like you said, nobody today, even in larger cities where people are more aware of these issues, will be caught parking their car in the parking lot of a psychiatrist. That's not going to happen. People, even in Chennai, I know psychiatrists have a back door for VIP clients. So that issue is taken care of. That's number one. Number two, the people who are actively seeking mental health are digital first clients. Young people just graduating, first job, second job, they're very, very comfortable going out and using these tools. Their challenge was, even if I were to use this tool, there's nobody on the other side. COVID has forced the other side to come on board. I don't think it's the customer who was falling behind. It is the supply that has now come on board. And I think that's a significant shift. And today, I think if you're in the mental health space, forget mental health. If you're in the health space, if you're not comfortable delivering at least part of your practice via online tools, I think your days are numbered. That's number one. Number two, if you are not comfortable getting online and providing care to your customers, look at the options the customer has. You are not the king of your town anymore. The entire world has opened up. Today, I can consult with anybody, right? I mean, if you're a mental health, if you need mental health for your family, I can go to the best available therapist in the country using this opportunity. So I think it's really shifting the game for us. And the sooner we normalize this, I think this would be very, very beneficial. It also, I think, needs to be integrated in a way like what Raviji mentioned, is it cannot be a handoff breakpoint, right? We will have to have referral linkages in the digital world as much as we spoke in the physical world, so that seamlessly cases can be transferred from psychiatrist to therapist to nutritionist to what all the other pieces are. But again, coming back to the main thing here is, what I spoke about, the role of community. In the digital space, how do we recreate a sense of community? I'll give you an example of how I got an appointment with a doctor recently. When you traditionally go to a doctor's clinic, you go there, you wait in the waiting hall, the receptionist speaks to you, you speak to a few other customers, you have a little bit of social interaction, then you go to the doctor, you come out, you get the prescription, you talk to the pharmacist. It's an experience. Today, at the appointed time, your phone rings, you talk to the doctor, boom, and finish. I think there's something missing there. The ecosystem is not allowing me to interact with other players. That's something that we have to figure out. It's very abrupt in that sense, the experience. So that's something that we'll have to build in. How do you bring the social and the community angle to telehealth?
Sure, Ashwin. One interesting thing now that you bring it up. So I've had 2 telemedicine consultations myself. One I just experimented checking on one line, and the other I actually had to consult my own physician. And when I go to my physician, we spend about half an hour. We talk about the whole world, and towards the end, last 5 minutes, he asks, "Why did you come here?" And I'll tell him the reason, and he'll give me a prescription. When we transferred this experience onto telemedicine, it was over in 7 minutes. He felt odd, I felt odd, and he said, "Okay, we're not talking about manga comics, or we're not talking about anything else. We just," and we are of similar age, so we can, we have a lot in common. But I think that experience has to be built. I think we are not trained for that. We are not used to it. We say, okay, it's a phone call, and phone call means just finish your job and then move on to the next call. But that physical experience has to be translated to a digital experience, which I think will take its own sweet time. That's a great insight, Ashwin. I can relate to it, what you talk about. So coming to Girish, given that we've traveled forth of this journey, taking about the broken system and the things we need to fix, the referral systems, SOPs, and the need that we need to have this whole ecosystem work together. How can we build this whole thing? How can we design this system that is built for outcomes? Identifying all the gaps, making sure the linkages are there, and ensuring that we succeed.
Okay, so Vikram, I think the years ahead, right? What is going to be the center of the entire ecosystem is going to be the National Digital Health Mission, right? That's going to be the center around which all of us are going to build our various pieces, right? So I believe that all the parties in the healthcare ecosystem should strongly partner and engage with the government and play a role in building the ecosystem. I think this becomes a center focus. If you don't do it, the system will have a lot of gaps, and you will find the ecosystem will be very fragile over a period of time. But I think more than this, right, there are a couple of other important points which we should consider. And one very important point is connectivity, right? It's very critical. So India should definitely get onto the 5G bandwagon much faster and efficiently build a very effective, I would say, information highway, which connects the PHCs with CSCs to tertiary care, etc. And this is very important because we need to have information at the right time, at the right level, right? That is very crucial. So I think building this connectivity becomes a very important element of the entire ecosystem play. The other very important aspect is also the level of training what is required to be in the ecosystem. So today, what happens is there is a huge barrier in terms of overcoming the educational need, training needs, etc. Right. So as a ecosystem, we should ensure that we take conscious effort to systematically reduce the entry barrier for usage, especially in tier 2, tier 3 cities, maybe tier 4 cities, right, where we don't have access to the high-end technicians or technologists. We have to make it much more simpler to use. We should have less training, less education needs, above all, it should be multilingual, right? Because if you look at most of systems today are in the local language or are in English, and how do we make it multilingual and localized to the system, to the local players? I think this is going to be a very strong enabler, which will percolate down the healthcare system. And eventually what I mentioned earlier, right, the quality of data, the quantity of data would have a direct impact because of this. So connectivity, the reducing the barrier of entry for the ecosystem players to come in, and these two becomes very important. And the last thing which I would want to again harp on is the startup ecosystem, right? So we should realize that the startup partnership is going to be a very big element of this whole ecosystem success. So we have to provide an environment where we can provide space for hundreds and thousands of startups to come into the ecosystem. So the policy directions has to be very congenial for these people to come on board. And more than everything, right, the healthcare players in today's space have to be open to provide the interface for these guys to come on board. Today, the healthcare system works in a very, very closed mode. Maybe we have DICOMs and HL7s and all those standards, but beyond that, we have been much more closed in providing a comprehensive ecosystem play, right? So healthcare players should really open up and ensure that we are able to get these guys on board. I think if we do these things, right, these 4 things in a very systemic manner, we should be in a very effective way, build an ecosystem which can sustain the test of time.
No, excellent, Girish. I think you've said it and you probably nailed it as well. Till we all come together, it'll be very difficult for us to build it. While everybody has got the best interests in mind, I think somewhere the best interests are not converging into something that will not only improve care outcomes, but also build that, like what Arvind said, build it for outcomes, create a system that is working together and focusing on outcomes and delivering the results required. So with that, I will just pause and see if there are any questions. I don't know if you're receiving questions on chat or are we receiving on the direct line. But if there are any questions, please type them in here and I'll be happy to take them on. One thing that I also wanted to just discuss as we wait for questions or just to sum it up, and I'll start with you, Arvind. Is that when you see the healthcare system where it is today, and this is just an opinion from your side, how long do you think it will take us to kind of reach a level in which we don't have so many gaps in our system? What is your outlook?
Vikram, I'm going to compare healthcare to information technology in India. Okay. India did not have great mainframes and did not have, computerizations in every aspect from the 1960s, 70s, and all of them, like many Western countries. But the advent or the necessity of knowledge during the Y2K got India into a lateral entry, and then after that, India shot up and became the go-to place of information technology. I see healthcare the same way for us. India is developing its systems. I don't think, and I will not feel comfortable at all calling Indian systems broken. We are maturing. Obviously, our systems are hampered because of the volume that we serve across the country. So, but I think with all these minds coming together and the necessity being well realized, the government, the private sector, the several players who are there, the startups who are coming up with innovative solutions and all of them, I think with all of that coming together, and more awareness and education built in the complete digital media and the surrounding information that surrounds all of us today with televisions and social media and all of that, the constructive information that I'm talking of, I feel that and also India being a very good and a responsible medical tourism hub for the rest of the world to come for high quality treatment. I would say that in 5 years from now, rough order magnitude 5 years from now, all the activities that we are doing, whether it's policy making or some amount of, setting up various formats of care delivery or outcome measurement or being consistent in terms of, delivery cadence. I think in 5 years' time, we will see a pretty significant level of maturity that other nations over the years have probably taken more than double digits or even 25 years to achieve. I see India doing that at a much faster rate because knowledge is there, the commitment is there, the nature of seriousness of the program is well understood. It's wrong for me to say, but still, thanks to COVID, it's brought all of these in the front and center for people to realize and put attention to. So I think we are in the right climate for all of this to happen. So I'm very optimistic. I would give ourselves about 5 years, and we'll see better, more mature. When I say better, not marginal, but definitely a mature health system coming out of this part of the world, which is not known for that level of maturity.
Thanks, Arvind. I think we have many optimistic people on this call, but
it will happen, man. It will happen. It will happen. So many people are there. It can't fail.
Thank you, Arvind. Ravi, your opinion, please. How far away do you we are?
I am completely with Arvind on this. I think if we can sort of transform our financial industry and our telecom industry the way it has happened so far with the type of reach that we have got, I think healthcare is not going to be very far away. And I think the healthcare assumes even more significance than the finance and the telecom from a need perspective. And people would simply want it, whatever the cost. And they said, like for example, let me step back again. If my mother at 85 can use WhatsApp, I'm sure industry healthcare to be there is not going to take that long. I agree with Arvind, and I wish that in the next 5 years we get to where Arvind is aspiring to be.
Great to hear. Ashwin, your opinion, please.
No, I agree. I think optimism is all we have. So we should use it. And,
well said,
no, but
Ashwin.
While I say it in a lighter manner, but the healthcare sector is inherently very optimistic. Look at the challenges we had to overcome to get to this stage. Right? So the target of 5 or 10 years is not too daunting. I think it's going to get there. It's a question of what Girish said, coming together of all the players on a single platform, whether it is for standards or for access, whatever it is, right? I think the age of siloed advocacy for our company is gone. I think we have to come together and say, let's do it for the sector. I think then this 5 year, 10 year, hopefully 3 year, we could do it.
Love it.
A lot is depending on you right now.
Yeah. And I would actually echo whatever Ravi and
Oh,
Ashna.
come on. I wanted somebody to disagree.
But I think, Vikram, the point is that there's a lot of skepticism, right? But I would really say that until COVID, no, we were probably as skeptical as ever, right? But I think we have realized that the healthcare system reacts very differently when we are forced in a corner. And I think COVID is a very good example, right? The way the healthcare system has been able to adapt, right, in the last 6 months is something which would normally take a decade to adapt to, right? The whole question of remote patient monitoring, virtual hospitals, telemedicine, telehealth. I'm 100% sure that the system was even FDA, right? Even the regulators have really transformed very swiftly in a matter of days or weeks, right? That is really something unexpected, because we always thought the healthcare system to be a huge, gigantic elephant which can't even move. It takes years to move around. I feel that the way we reacted to COVID in a situation where we are forced in a corner, if that is the transformation we can do, I think we have a lot of hope. It's just a matter of time before we get there. And honestly, Vikram, I think we are pretty much close to the wall, right? At this point, the only way we can come back is to make a very positive impact.
All right. Thank you, Girish. I think we have even I'm an optimist. I agree with Arvind. I think we have learned our lessons. We can do it in IT, we can do it in telecom, we can do it in banking, and we are doing it in retail. We seem to have a much more bigger hold on retail. E-commerce, I think we can definitely do it in healthcare. So thank you very much, all of you, for taking time out from your busy schedules and contributing to this experience. I had a very, very enriching exchange of ideas. And I'm sure whoever's listening to us also at least will be bitten by the optimism bug, if not anything else, and take home the fact that India is, yeah, apna time bhi aayega, right? Or aa gaya hai in a way. So thank you very much, and have a great evening. Back to you, Ravi sir, for the rest of the session.
Dr. Vikram, thank you. As always, thank you, participants, for taking time off from your schedules and being with us today. You have been a fantastic moderator as always, and today was no exception. So thank you, Vikram, for making our day today. And with that, I would I would want to welcome Mr. Sharat Sharma to sort of guide us on the infrastructure that we will be getting to see in the healthcare stack. And before that, maybe over to the host for an introduction. Julian.
Thank you so much. That was a wonderful discussion that we had this evening. Just to take forward with that, autism was the overall discussion. I hope that it creates a happiness. Moving ahead, without any further ado, we have Mr. Sharat Sharma, co-founder iSpirit. He is actually mantra to lead ecosystems and companies through orbit change. And he has over 3 decades of experience in internet, enterprise software, digital finance, and digital health, and is a prominent voice in India's technology ecosystem. It's very great to have Sharat on. Also a co-founded iSpirit Foundation, a non-profit technology think tank devoted to making India a product nation. Earlier, he chaired NASSCOM Product Forum in its formative years and member of the NASSCOM Executive Council from 2009 to 13. I now request Mr. Sharat to take it forward for the discussion.
Mr. Sharat, thank you so much for being with us today and for all that you are doing for the Indian healthcare ecosystem. We can't thank you enough for that, Sharat. So
you're very kind. So let's see, all the work is ahead of us, I think, collectively, as many of you mentioned in the previous panel. And, we have to live up to this optimism that was there in the panel. So it'll be important that we do many things right. I have 5 points to make. If I can get access to sharing of slides, I may use a few slides here and there, but I'll try and make those points without slides if that is not possible. So first is, let's step back here for a moment, because as
Do
many
you
of
want
you
access, Sharad? Do you want access for sharing the slides?
I can now share.
Okay, thank you.
Yeah. So first is that if you step back, COVID, as many of you mentioned, has been a great teacher. So let's kind of examine a little bit of what a future health system should look like. So first is we have to accept that symptom-based diagnosis will go away. Just in a case of a potential COVID patient, you couldn't diagnose a person based on symptoms. You had to do a test, right? And without the test, you wouldn't know whether that person was COVID positive or not. Now, this is actually going to happen for all diagnoses as we go forward. 10, 15 years from now, symptom-based diagnosis will not be the norm. There will be biomarker based, which means you would do a blood test, you'll do an X-ray, you will do some kind of a test, and actually it will yield lots of information. And then, somebody will synthesize that information, perhaps, a AI system assisting the doctor to actually be able to do the diagnosis. So this is a shift that is taking place. In this, there's an opportunity. The question for us as India is, can we democratize this fast enough so that an ordinary Indian can avail of better diagnosis than, let's say, an ordinary American can, right? And so answer to that is yes, we can, provided we think about this early enough and we factor this in our planning as we go forward. Second, once you've diagnosed a person, then you need to triage. Because the fact that I'm COVID positive and I have, let's say, many comorbidities, versus my friend who is COVID positive and has no comorbidities, means that our treatment has to be different, right? I may need to go to a hospital, that person may need only home quarantine, right? And how do you know that? You know that because my medical history is available at that time for somebody to look at, right? And as is the case with my friend. So this is therefore the fact that we can bring longitudinal health information about every Indian up to the surface in real time at the moment when this has to be evaluated is going to be very important as we go forward. Now, essentially, the question is, can we make that shift happen? Can we get to these personal health records, which are going to be available to everybody? Can they happen in a way that are privacy preserving? Can they work in a cultural system where, I may need to separate my information, based on my reproductive health versus mental health, as some of you pointed out, people still have that cultural bias against sharing that medical information versus regular health, right? So the quote unquote, the test of this is, can we have our medical history available to us and our doctors instantly, but putting these caveats in mind? So can we manage a situation where a young girl who's got married, and the new husband says, hey, now that we are married, can you share with us, we should share our medical history with each other. And she's claimed she's a virgin and her medical history shows that she's had an abortion. So she can't afford to share that. So can she now keep that separate, because that is what the cultural imperative is, and yet bring it up when she needs to, right? So can we do this in a manner, and this makes it much more complex than many other countries in the world? And the answer is yes, we can. Right? So that's going to be very important. And on the back of that, would you have this ability to triage as you go forward? Now, once you've triaged, then you need to find the provider. If you're doing home care, you need a provider for that. If you're going to a hospital, you need a provider for that, and so on and so forth. Teleconsultation, you need a provider. OPD, you need a provider, right? So you need providers. Can we move to a system in India where these providers are recommended to me without kickbacks? Because let's accept it. Our system is broken today and it is based on kickbacks. And that is not going to be an acceptable system as we go forward. So what will it take for us to devise a system where a patient now has an ability to make good choices about providers, but based on what's good for the patient, not good for somebody who's recommending the provider for them, right? So that's going to be another facet that's going to be very important. It's going to be a very big shift as we go forward. But is it possible? Yes, it is possible. Then we are talking about this whole thing saying, okay, I was in the hospital, I've come back home, I need some, continuum of care, I need aftercare. If I'm a cataract surgery patient, how do we improve the post-cataract surgery care when I go back to my village, right? It doesn't happen very well today. How do I make this happen if I go back from the hospital and I need ongoing physiotherapy? For all of us who are 30 million Indian families, we call them Californian Indians, who live like Californians do. This doesn't appear to be a problem, but it is actually a very big problem on the ground. And so we got to figure this out in a manner that makes a difference. Then COVID, we will get into this mode where sooner or later we will have to deliver vaccine potentially to 1 billion Indians. What will it take for us to do that well? Right? We don't have a paradigm in place that allows us to distribute this vaccine in a sensible fashion, taking it into account, again, triaging who needs it first. Hospital workers need it first. Elderly people need it first. Maybe some people who are affected need it. How do we make this happen without this devolving into whoever has the money will get the vaccine first, right? And so we have an opportunity to do this right in the next few months. And whether we will or not, time will tell us. And you may have read, Nandan wrote about this in 2 articles. There is a plan in place. Let's see if we are able to embrace that as we go forward. Then finally, the best way to deal with health is not by remedial, not by fixing people when they are not healthy, but actually keeping them healthy, right? So what can we do for wellness? And, we are one of the few cultures in the world where wellness is ingrained in our culture. We have no problem accepting the idea that we should do something. Yoga is a manifestation of that, as are many other things. Our intrinsic and our old medical systems focus very, very intensely on wellness. And therefore, we have this ability to make that happen. How do we gamify our population for wellness? Especially, how do we do this? Not for, again, the 30 million Indians where, you will have a Healthify Me or a Go-Key or companies like that who will try and keep you well, right? But how do we do it for the 100 million families which are at the bottom of the pyramid here? They are part of Ayushman Bharat. How do we intervene in their lives in a meaningful way, in a sensible way, so that we can improve the odds of actually keeping them healthy? And the upside of doing that is very, very high, because human potential is a beneficiary. And of course, healthcare costs will be down. And remember, in Ayushman Bharat, our average age is only 27 years. So if we can do that well, the payoff for that is very significant. So why did I start like this? Because I want to start like this by telling you first that, look, it is a new template that we have to put in place in each of these areas. Our existing templates are not going to give you the answers to this new world of healthcare that we are looking at as we go forward. So where does that template come from, right? So now, of course, some of that template is coming from the National Digital Health Mission. And this is where, let me shift gears and throw a slide at you. And I promise you that I'm not going to throw many slides at you, but throw one slide at you and see if that makes sense. And so this is the slide that you see, which is the National Health Stack slide. And Health Stack, the manifestation of the Health Stack in the government is called the National Digital Health Mission. Manifestation of that in the private sector is in the hands of the private sector. But there are very thoughtful private sector players that have started coming together in various fora. One of the significant ones is Swasth Alliance, and which is a way to accelerate the rollout of the health stack. Now, I'm not going to go through the health stack because we don't have the time. And if you really want to go through some of this, there are open house sessions that are available on the iSpirit YouTube channel. But essentially, it has 3 layers. It has a plumbing layer, which is where the focus is essentially on personal health records and some other registries. Then it has an augmentation layer. And then it has what is called as an ocean layer, open health services layer, where the focus right now is on teleconsultation, telemedicine. And so this is something that will come to life over a period of time. Now, I could spend a lot of time talking about it, but rather than do that, I actually want to explain the thought process behind this, right? Because I think understanding the, you see a date here, it says 31st July. Why these health stack slides are all time-stamped is because they are evolving as we speak. There is no such thing as immaculate conception. You will find that they will change. They'll not change fundamentally, but they will evolve as we go forward. And therefore, you have to see the timestamp version of this as you see. So I want to bring up another slide and explain how to think about it, because then that will allow you to actually be able to follow along and understand better how these things will change as we go forward. So let me see if I can bring up another slide here. Can you guys hear me okay? I'm noticing there's something here.
Not able to see, Sharad. Not able to see.
Okay. Now, let me bring up another slide. The way to think of health stack really is in context of what we call as the Jugalbandi architecture.
We just lost a slide, Sharad. We just lost a slide. Can we just flash it again, please?
Yes, I will. Yeah. So it was actually the wrong slide. I'm going to come to that slide a little later. So I wanted to introduce this Jugalbandi architecture. The Jugalbandi architecture is that if you want to solve India's hard problems, you need a Jugalbandi between public infrastructure and private innovation. So the way to think of this, and I'll bring this to life in the next few slides. There's a lot of background noise, but I'm going to bring it to life in the next few slides. You bring it by saying there's a problem that you're solving, which is the problem in the inner circle that is solved by various providers. These providers can be public sector providers or private sector providers, both of which use public infrastructure to make something possible. Right. So this is the idea. Now, many of you in the previous session kind of talked about and said, hey, we made some changes in the financial sector. Can we bring this to life in the health sector? And that actually is very true. We have made many changes in the financial sector. So I'm going to give you an example from there. I'll run through a few slides just so that you can see how it's worked out in that sector and what would be the analog for it in the health sector as we go forward. So the way to think of it is Rajini, she's going to get an intraday loan. And what happens is there are again this whole dynamic that is there, right? And the dynamic is that the inner layer is what Rajini does. She needs a loan, she applies for a loan, and she does a bunch of things to get an intraday loan. What the middle layer does is the lender provides all these services. What the outside thing does is for actually the public infrastructure that allows the lender to give a loan in a way that was never possible before. So let's think of it for a minute. If you want her to get a formal loan, she has to do a KYC. If you go back to 2014, paper KYC was only possible that would cost 50 to 60 to 100 rupees. It wasn't viable. So you needed to introduce something called eKYC that reduced it. When Jio used it, it was 6 rupees in KYC. Today at scale, it is 2 rupees a KYC. She needed to sign a loan agreement. Today, she can do this on an ordinary phone and make that signature happen, right? And that is at 1 rupee e-signature. India is the largest user of e-signature in the world. She does not even need a smartphone for this. She can do this on a feature phone. She doesn't know how to use Google Cloud or OneDrive. So where does she store her loan agreement? Her loan agreement gets stored in DigiLocker. If you have heard of DigiLocker, that is where it gets stored. Right? If she's done that, how does she receive the 500 rupees in the morning and send it back in the evening? UPI has turned out to be the mechanism to do that. Then if you have two Rajinis, one pays on time, one doesn't pay on time, how do you make sure that the one who pays on time gets lower interest rate? So there is something called the account aggregator that gives her the portability, and PCR, public credit registry, that gives her, her ability, for others to see who's actually has a better credit history. So there's a bunch of stuff that is coming collectively called the India Stack. Now, why this is important is that it changes the way we develop solutions. See, in India, what we have had is, we have been used to developing very complex solutions all by ourselves. It is like our housing societies. Like I stay in an apartment complex here in Bangalore, and I'm telling you, if I don't get municipal water, it doesn't bother me. I most of the time even don't know that is the case. I don't get municipal electricity, the building generator kicks in, I don't have to bother about it at all. Right? So we've created these enclaves where public infrastructure is replaced by private infrastructure. But that's not a scalable method. So now what is beginning to happen is that we cannot fix the public physical infrastructure in most cases. But in the case of digital infrastructure, what is beginning to happen is that India has got that religion and is beginning to create this digital infrastructure in advance of the private players building the applications on top of that. Much the same way, if you want, in the US, you go and you want to build an office building, the plumbing is all in place. There'll be electricity, there'll be sewage, there'll be water. Then only the actual builder will start construction there, right? And so this is the idea. This is the shift that we are talking about as we go forward. So the attempt is not to merely do this for financial inclusion, which is a very important problem, a national problem to solve, but also do it for health so that we can get to that health vision that I described to you a little bit around COVID some time back. Does that make sense so far? Are you with me so far? Am I making sense?
Perfectly, sir. Sounds good.
Yeah. So I will make one more point. So I've so far talked about a number of things, and I want to make one more point here. And then open it up for questions. So for this to work, essentially, there is another concept that is very, very important for us, right? And the concept that is important for us is the concept that three things have to come together to bring this to life, right? If we want to do this, yes, we need the infrastructure, but alongside the infrastructure, we also need the policy and market participants, right? So I earlier talked about the jugalbandi between infrastructure and market participants, but we cannot forget policy. And I like to give you an example, and this is thankfully happening. This is what's happening in credit. This is what's happened in payments. Our Indian payment revolution is related to that. But I want to take you back to 1988, right? And talk to you about television. In 1988 was a time when PAMSAT and then soon INSAT came, right? Now that changed the game. Why did it change the game? Because till then, if your city wanted television, you needed a Doordarshan tower. And the Doordarshan tower, if you had an antenna on top of your house that could, could be within the visibility, radio visibility of the Doordarshan tower, you would have TV. Now, the reality is that although TV in India came in 1965, 65 to 75, you went only to 8 cities. And then Asiad was coming, as you remember, in 82. So the government of India said, hey, we must speed things up. So they did speed things up. So from 75 to 85, we got to 34 cities. So, many of us are here in Karnataka. There were only 3 places. You had Gulbarga, you had Mysore, you had Bangalore, but if you were in Kolar, you didn't have TV tower. So now when PAMSAT and INSAT came, that problem went away. Anybody could now buy a dish, and they did, and wire up that town so that everybody could have TV. But you know what? If all they could watch was Doordarshan, Krishi Darshan, they wouldn't pay that cable television guy to watch TV, right? So what really changed was the fact that Prasar Bharati bill was coming that allowed for more interesting programs to be available on Doordarshan, private programs, some of which you will remember, Hum Log, right? And Mahabharat and all of that. And that is what kind of pulled people to actually pay those cable television guys who would then buy the dishes. And then in 7 years, we saw the TV viewing population in India from 1988 onwards to 95 grow 25 times of what it had grown in the previous 23 years. This is the same thing that's happened with cashless. In less than 3 years, We've created a payment system because of all the three things coming together, where we have more transactions that happen in India than all credit card, all debit card, all ATM transactions put together and more. Not only that, yesterday we did more transactions in India than we did for American Express did worldwide. In 2 years, we will do more transactions in India than MasterCard will do worldwide. It's even an inconceivable number, frankly. But why that's happening is because all the three things are coming together. So coming back to health, this is really what our opportunity and challenge is. We need to do the infrastructure side. We need the new age participants, providers, both in the government sector and the private sector, to embrace this infrastructure, leverage this infrastructure. But most of all, we also need policies that will make that happen. And I would share some of the optimism that was there in the previous session, that yes, all the three are beginning to come together. And therefore, the next 10 years are going to be very, very exciting. And if we play this well, we have a chance to reimagine our health infrastructure, our health providers, and our healthcare system for the future. So with that, let me open up for questions. I'm happy to take any questions if there are.
Sharad, this was fascinating. 30 minutes where you sort of enthralled all of us with what the future of healthcare is going to look like in India. And it sort of also adds to the optimism that I always had, that the panel always had, saying that India is going to be different in the coming years. And you only re-emphasize the fact, big data points saying how India has transformed and healthcare is no different. So open to the audience for questions, Sharad. And thank you so much for this wonderful presentation. Okay, if there are no questions, then maybe I'll ask a question to you, Sharad.
And this will allow us to quickly catch up on time. I think my session was supposed to end at 7:30, so I'm thinking that Mukesh is next, and so it will probably help.
I'll ask one question. That was always sort of which I always had in my mind, saying, when do we think that the private companies like the Philips and the GE and the Siemens, along with the smaller players, can actually onboard the health stack?
See, I think the sandbox for the personal health registry is already up and running. There were 180 applicants to NHA, and I don't know how many they've cleared, but they've cleared out many of them. So certainly 100 plus players are already up and running as we go forward, right? And then Swasth is very focused on taking its members to embrace this also in a big way, and I'm kind of hoping that Mukesh will talk about this. So I think one part of this, the plumbing part of this, which is to do with the personal health records, is up and running. I think the next piece that will fall in place is going to be telemedicine. And there will be, both standards and infrastructure that will fall in place for telemedicine. And that will give us as a country to start scaling the telemedicine service providers, right? And so with an experience that is somewhat consistent, high quality on the front end, and with choice, because you don't want to take the choice away from the patients, right? And they should be able to exercise that choice, but they should have minimal standards. And I think, therefore, the role of self-regulation is going to be very important. And all this is coming. I think it's weeks away. It's not even months away. And I won't steal the thunder because Mukesh may want to talk about this. But this is really what is the next piece that will come. Then after that, you will figure out that claims will come, because this is all plumbing that is coming. We want to get to a point where India is a very peculiar market because our insurers don't pay for OPD. While it is in everybody's interest to pay for OPD, right? If you can catch the fact that I have cancer in an OPD visit early, everybody saves money. It's good for my outcomes. It is good for the insurer as well, and it's good for the health system, right?
That's right.
But we don't pay for OPD because it's rampant. OPD payments are rampant with fraud. So can we come up with and the cost of processing a claim from OPD is very high. So what is coming in the future is a new age system for settling claims, where essentially small value claims, 150 rupee claims, can be instantly settled without fraud. Now
Okay.
that will roll out early next year. So until those things come, you don't put the foundation for many other things that we talked about. Protocol servers will come, which will give you standards of care, right? Yeah, and so on and so forth. Many things will come. We don't have time to go through all of this, but that journey has begun. And the first leg of that journey is live. So we're not talking about vaporware. We're talking about something that's already available, which is the personal health record. And therefore, I would encourage people to start using that as we go.
Thank you, Sharad. Thanks a lot. It's
So
been
with that, thank you for inviting me. I really enjoyed the last session, and it was really very, very, very good. And wish you all the best. Thank you so much.
Thank you very much. Thanks a lot for spending the time with us, spending the evening with us. Really appreciate this, both on behalf of myself and on behalf of the CII team.
Thank you.
Over
So
to
I'm
you,
going to spend on a little
Manjunath.
bit, and hear a little bit of Mukesh if he doesn't mind.
Yeah, of course.
Absolutely, sir.
So much.
Welcome,
Thank you
Mukesh.
so much. And hi, this is Manjunath, and kind of going to host this particular session now with Mukesh. Hi, Mukesh. Good evening. Thanks for taking time and joining.
Good evening, Manjunath. Thanks for having me. Looking forward to this interaction.
Good evening,
And,
Mukesh.
Good evening. Ravi.
Yeah. And also, on a personal note, I am a user of CureFit, and I'm a customer, and I thoroughly enjoy, being part of it. So thanks for creating it.
Oh, brilliant. Good to thank you.
Fantastic.
I'll be your next customer, Mukesh.
Well proud, Ravi.
No, you should. It's a very good one. So as an introduction, I think, most of the people should know, but then, I have the privilege of introducing, it's a long 2-pager bio, so we will not take so much time. Just as a quick introduction, obviously, Mukesh is a technology entrepreneur with over 2 decades in this field. I think the best way we know him first is as a co-founder of Myntra, and then, the latest one being the co-founder of CureFit. So we will not spend too much time, on discussing the CureFit itself, because I think today there is a bigger agenda that Mukesh, you're here to talk about. So do you want to then straight away get to the topic and share with us what is Swasth, and how is it going to help? I know in the previous session we touched upon it, but if the audience can get a detailed view of how it's going to help all the citizens of this country, I think it will be a good start to this conversation.
Definitely, Manjunath. I think it's a good segue. I will probably pick up from where Sharad left it off. He has already paved a lot of background for Swasth, both in this discussion and then in general, over last many years. So, as the pandemic hit the country, a lot of us in the VC community and entrepreneurial community in India, we came together and started asking what can we do to be relevant and help the country in this time of need. So that led to creation of ACT grants that many of you have heard of, probably contributed to also. It's a 100 crore fund that we use to fund a lot of innovation in the COVID context. And in the very early days of COVID, it was clear that to manage pandemic at a large scale, if we had a telemedicine infrastructure along with the home remote quarantine facility, we will be able to manage large number of COVID cases at home. So ACT decided to kind of seed fund Swasth as an initiative, which is where we reached out to number of people in health tech industry, some of the major hospitals, some of the well-known medical professionals in the country, and we said, can we all get together and try to cobble up a telemedicine platform very quickly, which we can take to central and state governments, and which becomes go-to destination for most of COVID needs. So that was kind of initial genesis of Swasth. In the very early days, we came in touch with Sharad and some of the other architects at iSpirit, some of the folks at NHA, Niti Aayog, and got up to speed on all the work that had happened on health stack. I think a lot of conceptual thinking has been in works for many, many years. So by now, the entire protocol and what we're trying to solve was fairly well fleshed out. And here, because using COVID as a trigger, the entire health industry was coming together to create this platform. So it made a lot of sense to join hands and build the entire source platform on top of health tech protocol, which was eventually got announced as a national digital health mission by Prime Minister Modi in his 15th August speech. So last 4 or 5 months we have been building source platform using NDHM protocols, and some of the components that are built out or Swasth is helping build out. It has grown into a large consortium over 100 health players, and we are slowly opening it up to much bigger set of players. The idea is to create this open source public goods software infrastructure that can be used by any private or public player to provide health services to any citizen of the country. Swasth is very heavily leveraging all the work that's being done for the National Digital Health Mission and working very closely with all the teams involved. So we are very excited. This is the first time I think we are seeing an initiative where entire health industry of the country has come together and working in a very collaborative open source mindset where we are able to iterate very fast. We have released number of features and solutions in last 4 months, serviced tens of thousands of customers. Many states and districts have deployed our solution. NHA is looking at what we have built very closely to see how we can use it at national scale. So it's a pretty solid progress in last 4 months, and I think we are the start of something which can play a very significant role in creation of the digital health infrastructure for the country.
Fantastic. And by the way, I think it's a great job that you have all taken up, and I think it's going to be transformative. So if you could just continue this story and tell us, what does it mean to me as an individual, an average citizen of this country? What does it mean for if I'm a doctor or a practicing nurse or whatever? So what does it mean for all of us?
Right. So this answer will evolve as the Swasth platform itself evolves. So I'll give maybe a two-part answer. What does it mean today, and what does it mean, let's say, 6 to 9 months down the line? So today, for COVID, we were providing free COVID consultation to anybody. People can just go to swasth.app and based on their language preference, etc., they can go through a automatic systems checker. And then if their situation warrants a teleconsult, it will be queued and doctor will call you back through any kind of telemedicine interface or IVR interface. Similarly, on the doctor side, any doctor can register on the platform and provide their service. Our current set of solutions so far were in the COVID context, but we are now expanding Source platform to offer services beyond COVID, the entire multi-specialty across variety of OPD consults for many specialties. We are working on integrating with various payers, including many insurance companies. So that should come in the coming months. When the entire health stack is released, if you are a healthcare service providers, you can just register using NDHM as a one core component of DigiDoctor, where you can register, provide your credentials. Once you're registered, you become discoverable on the in the directory services, and any telemedicine service provider who is providing telehealth services using NDHM, that doctor will show up as a provider. So you get access to a lot of demand across the country. One of the things you've seen, the access to healthcare and the availability of suppliers is not very uniform throughout the country. When you're having pandemic in one place, the doctors there are super busy, but doctors in other places are not busy. We have seen many doctors who become part-time doctors or live in smaller towns. They don't have access to a lot of demand. So using the entire NDHM infrastructure, the doctors will be able to service patients throughout the country. Will be able to have much better supply demand matching, and because the entire platform will be built on the same health stack, there will be a lot of interoperability. From patient point of view, you will have continuity of your health records. So every time you interact with any provider, you will be able to pull up your entire health history, which can be factored into whatever health transaction you are having, whether it's just a simple consult or a hospitalization or an insurance claim. Your entire health history will be available just with a simple consent. So both from patient point of view and doctor's point of view, it will be much better quality of service, as well as expansion of the market that the platform will enable. I should clarify, the difference between SWAST and NDHM. You can think of NDHM is the underlying protocol which is enabling this for eventually any provider in the country. SWAST you can think of as one reference app, very similar to how Bheem was developed on top of UPI, and it became first, app which catalyzed the or digital payment infrastructure for the country. So SWAST is, equivalent to, let's say, Bheem app, which is a reference implementation of NDHM.
Very nice, very nice. So I'm sure you've all designed this platform for the national scale, and you would want millions and millions of them to be participating and using. But have you seen, or do you believe there are any? I mean, the customer experience will change, right? I mean, instead of me walking into a primary care center here versus going into this app and trying to get the healthcare that I need. So, what are the kind of experiences that you think will change, and what are you doing to encourage patients or citizens to enroll into something like this?
Yeah, I think I believe, Manjunath, that the whole industry will go through this inflection point. A lot of trigger points are coming together, which are driving behavior change. The pandemic itself is a very big trigger. I think last 5-6 months, many people have not been able to go to hospitals. A lot of individual clinics have been closed. Doctors have not been practicing for the fear of potentially contracting COVID and so on. So a lot of those, doctors have shifted to consulting customers online. It could be a simple Skype consult, sometimes just over SMS or WhatsApp chat. Similarly, many people have tried telemedicine first time in their life, and they are seeing that, for many of the cases, the experience is as good or even better, because, you are able to, the entire consult is done in just 5 to 10 minutes. So you save all the driving time, showing up at doctor office, waiting in the queue, sometimes waiting up to an hour for a 5-minute consult. So before you know it, half a day goes into for a simple consult. Here, in the online medium, you are able to do a follow-up consult very easily. If there is a prescription, you can place an order right away again using online medium, or order a home test. So the experience is very, very simple, easy, fast, and transparent. So one is, because of pandemic. Second, the government is starting to put a lot of its weight behind promoting telemedicine. In last 5-6 months, many states have rolled out various IVR solution. Some have worked with Swasth app itself to enable telemedicine for their constituents. Many central government agencies are actively working on promoting um, telemedicine. Prime Minister Modi has talked about multiple times in last 3-4 months how telemedicine can be a great equalizer. So we expect a lot of promotion and push from government. And last but not the least is various payment mechanism coming in. I think it's a matter of time before we start to see some OPD insurance. And as a patient, if my OPD is covered and there is a, let's say, payment mechanism by government or private insurance players, so, and where they can also nudge users towards using telemedicine as a default mode. So I think all these elements will come together, and at some point we'll see a hockey stick growth in the telemedicine access, which will do wonders, I think, to overall health access, democratization of health services in the country, not only for consumers, but also helping grow the market for all the practicing doctors.
Right. Now, I think that democratization piece and also the demand supply gap that you spoke about, right, between whether regions or situations, and also given that urban versus rural kind of a situation that we have, I'm hoping that kind of will greatly get leveled.
Yeah.
So in such a construct, how do you see the commercial models evolving? What does it mean for a hospital, for a doctor, for the providers, government, etc. And where do you see this becoming profitable? As in, investing in these areas versus somewhere else. Why do you see this as a primary area to be invested in?
Right. Yeah. So I think there are two parts again, Manjunath. One is the entire health stack is envisioned as an enabler, and technology obviously should not be a barrier to play in the market. So all the work that's been done on the for NDHM and through Swasth app, the entire technology will be available free of cost to any participating health service provider, no matter how big or small you are. So the cost of entry basically become effectively nil. If I'm a doctor and I have interest in telemedicine, I can simply register through NDHM or with any of the providers. And I can use software that's available to me for free to offer really world-class telemedicine services. So that's one. Second, the from the provider point of view, if you're a doctor, you obviously your core differentiation is your name, reputation. That's why patient come to you, and in the online medium you can access a lot more patients, and over a period of time your rating, reputation will grow, giving you access to more market, more patients. If you are a organized provider like a hospital or a telemedicine company, etc., you can build more value added services on top of it. People can build all kind of interesting experiences. Sharad mentioned wellness, for example, a very integral part of our culture, and increasingly world over it is recognized that any good healthcare system should have a lot of preventive and primary care elements built into it. So you can imagine service providers creating service which is not a simple doctor service, but also how do I keep you healthy on an ongoing basis. People creating different kind of interesting bundles, being able to let's say do interesting risk assessment based on health history, and then creating solution on top of that. So what health stack will enable is provide this seamless, very low cost digital health infrastructure, and all the providers, based on their expertise and their point of view, they can then build more value added solutions, where they can capture value from commercial point of view, and the customers who see value in the new products and services that are being offered. And why it is important is today innovation healthcare is very difficult. There is really no digital infrastructure available. There is no access to patient health data history. Every time it's a fresh transaction, patient go from doctor to doctor with a physical file folder in their hands. It's difficult to believe that we live in 21st century when you see how transaction happen outside a doctor's office. So all that friction goes away. We have the seamless plumbing layer, so all the lower level work is done through this through the NDHM architecture, and then provider can just focus on building the value added services on top, and the innovation will be just limited by their imagination and their ability to spot opportunity in the market, build a solution quickly. I think we should bring a lot more entrepreneurship into sector. It should bring lot of VC dollars into the industry, and we should see emergence of lot of innovative services for solving broad variety of healthcare needs.
Right. So what are the kind of timelines that you're looking at, Mukesh, for these rollouts and the services reaching the citizens?
Yeah, it's very imminent. It's not happening as we speak. Sharad mentioned matter of weeks, right?
Yeah.
So just from Swasth reference app point of view, a significant part of the platform is already ready. It's available in the public domain. We are deploying it through various state governments. It's available as an end user service also. So that's one part. For NDHM, many components are built out. Some are available as a sandbox for providers to get their hands dirty, understand how the APIs work. There's a weekly open house being done to train people on how to use the NDHM components. We should see some of the public release start to happen in coming weeks and months. And my sense is, within this entire national reference app, may not take more than 6 to 9 months, at the outermost limit. And again, 6 to 12-month time frame, we should see a lot of health service providers start to offer services which are built on top of NDHM. So it's really short time for entire NDHM Swasth alliance, and large group of volunteers as well as many government agencies are actively working as we speak, and we are very much in the implementation delivery mode now.
Excellent, excellent. So as you roll out, obviously, the one critical question is of privacy, data privacy, and how privacy is being handled, managed in this platform. So do you want to spend a minute on how we are taking care of privacy issues?
Yes, absolutely. I think there are two very important component. One is not directly related to privacy, but just having a centrally verified list of doctors is going to be big enabler, so that patient, whenever they're interacting to a doctor through this platform, they know they are dealing with a verified doctor and not any quack, right? So that's very important from trust building point of view. The entire architecture of NDHM is designed to be decentralized architecture, where no single provider, whether it's government or intermediaries or end users and service provider, nobody owns the data. The only custodian of data is the patient himself or herself. And every time I interact with the provider, the whatever data is generated, the provider only has access to that, and that kind of lives in a vault. And even that provider can't use the data unless I give an explicit consent for a single use. So my health data may be with multiple providers, generated over multiple years, and but they're all linked through my unique health ID. And every time I have a new use case, and I think if I think it's useful for me to give access to my health data for certain use case, I can give that consent, and based on that consent, the new provider can pull out that health data, use it for that single use, and will have to destroy it afterwards. So there is there is no central place where all the data is kept, and there's a chance of data being misused for any reason. The whole architecture supports very detailed audit trails about any access to data, and then everything else is also designed to be compliant with the new data personal that data protection bill that is being considered. We are using cutting edge encryption algorithms, etc. So it's obviously, I think it's a very important point. The trust is very, very important in the health system, and it will be a critical factor in success of the entire health stack. And I think we are paying a lot of attention. And last but not the least, we're also working with the central government, including the Ministry of Electronics and Information Technology, so that they are also looking at the details of how the security is being managed and ensuring that it's compliant with all the approved government standards.
Right, 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 right. So with all of this good work with Swasthya and all the work happening in the healthcare space, where do you see the Indian healthcare system headed? Do you think we're kind of trying to emulate something out there which you believe is good, or are we going to create a gold standard out there in the coming few years and decades where the world will look up to India to say, hey, what this is how the healthcare system should be designed?
Yeah, no, I really think that we are building something which can be a gold standard reference for the world. In 5 to 10 years time frame. I think there are a lot of things about India are quite peculiar. Many of the Western system, they don't apply directly, and they have their own challenges. There are obviously some good parts, like in the national health service in UK, how primary care plays a critical role. So I think growth of primary care is very important. Really, no country has done a very good job of digitizing, patient health records, so that or a centrally, verified doctor registry. The ownership of patient health record with patient is quite unique. So I believe we are creating a new template, and when I say we, I should give due credit to all the thinking that's done by the iSpirit team, Ministry of Health, National Health Authority, and Niti Aayog. They've been thinking about these topics deeply, and the final architecture that has come out is quite unique. I think it's ahead, compared to most healthcare system in the world, because we had the advantage of hindsight, looking at what different people have done, what works, what doesn't work, and many of those healthcare systems have their own challenges, and they're really bogged down in very high expenses without necessarily proportionate health outcome. So I believe what we are building is going to be tempered in the future, and when the NDHM is fully built out and where we have entire health system of the country fully plugged into it, it will be highly efficient system that I think a lot of other countries will look for as inspiration and potentially adoption in their respective countries.
Hmm. Excellent, excellent. So I'm getting a question on the chat here. So it reads, do we actually need a massive IT infrastructure to drive all of these services? Just like the way you would need satellites to which kind of drove the TV revolution, telecom revolution, etc. So are you imagining like some centralized organization, government, authority creating this large infrastructure that everyone then bets on?
Yes, yes, I think it's a very important point. As I mentioned earlier, the idea is to not create a technology barrier for any potential participant, and the entire infrastructure is being created in the public-private partnership. On the public side, many central government agencies are involved. They've set aside budget also for developing many pieces of the NDHM blueprint, and then a lot of private companies have pooled their resources and they are contributing to development of many other complementary components as well as adoption and integration, and all this work has been done in a way where everything is available in the open source domain, so that technology is not a barrier to everything. We have over 1 million health service providers when we count all the individual doctors, not counting Ayurveda doctors, and which is another billion or so professionals. So we eventually want all of them to be able to just plug and play, get on board in the system, have access to all the capabilities of the platform with just very lightweight verification and certification. So I really don't think there will be either a huge infrastructure cost to participate or there'll be any barrier to entry for any provider.
Excellent, excellent. Again, another question from Kedar. So he says, there seems to be a clear benefit for the citizen and the government, etc. But how does the service provider make money out of this? What is the commercial model for
No, I think
a
commercial model
provider?
is very simple, right? It's just, see, today also service provider have range of services. It could be consultation or diagnostics or medicine or hospital service, right? Or wellness services. So we'll provide all the services. It's just that, you would have access to much broader market, and you will have the ability to stitch many of services together to create new services. You'll be able to factor in patient health history in creating more relevant personalized solution. You'll be able to, with all this data will enable creation of many AI-based solutions. So the cost for providing service goes down, but ultimately you are charging for each service. And I think it will also spur more innovation and deeper adoption of insurance. So if I'm a health service provider and more people have health insurance coverage, that means my potential customers goes up. So I, as a provider, will benefit from access to more market, which has the ability to pay via insurance, which doesn't exist on a large scale today.
Excellent, excellent, excellent. Superb. I think we're kind of a little over time now. So one last question, maybe, in this whole journey that you're going through, do you want to share a few, experiences of sorts that you felt energized or excited, or anything that you think, that would be good for us to know in this whole, apart from all the platform and the code and everything else?
Definitely, I think it's been a fascinating journey. Huge learning experience and inspiration last few months. For me, one of the very inspiring facet of this whole thing is entire health industry coming together and working as colleague. Many of us are competitor in our day life, where we compete. But in the last 4 or 5 months, we have gelled very strongly as one team. Players from let's say from Practo and 1mg and Pharmacy, Policy Bazaar, Apollo, Medanta, Columbia Asia, you name it, we all working as an extended management team, and the spirit of public, contribution and willing to be counted and making a meaningful difference for the healthcare system country, and people rising above their, day-to-day affairs, commercial interest, I think have been extremely touching and humbling experience. One of the best experience of my life. And other, big highlight for us, Swasth team was an opportunity to present the entire solution to Prime Minister himself, where he gave us an hour and we were able to give the demo of the entire app and the thought process behind it. And he was extremely supportive and encouraging of the entire initiative. So there was a huge boost for this whole initiative, right? So those are a couple of things that come to mind.
Superb, superb. So congratulations on all this great work, and we all want to support and contribute as much to this journey. Thank you so much for taking time. There are several questions still pending on the chat box, but I guess we are a little over time and we will have to call it a day. Thank you, Mukesh, and thank you everyone who have joined to listen to this discussion. Hope you all found it interesting.
Thank you very much. Thanks for inviting me, and I'm extremely thankful for CII for this opportunity, as well as we'll be counting on continued support from CII as we build out the digital health infrastructure for the country. Thank you very much.
Mukesh, once again, thank you on behalf of me, Manjunath, and CII for having taken time and spent it with us. It's been a very, very invigorating session, and it sort of adds up to the momentum of optimism that we are all building together. So, looking forward to staying in touch with you and working hand in hand with you.
Absolutely, look forward to Ravi. Thank you. Good night.
Thank you, dear. Thanks a lot. Over to Julian. I think we are at the end of the presentation today.
Yeah.
Yes. Thank you so much. That was a wonderful discussion had with all the extreme expert panelists on board. We now close with the closing session for the evening day. And we now join tomorrow morning for the third day at 9:45. I would thank all the participants who have joined this evening for a wonderful discussion that we had. With this, I also take the opportunity to thank all the program committee for designing the entire program structure. That is Mr. Chris Gopalakrishnan, Mr. Vijay Kumar Ivaturi, Dr. Gopichand Katchagatta, and the individual session coordinators for all their continuous support and inputs. I also like to thank all the companies who have been associated with the summit. We also thank all the exhibitors who are showcasing their products through the virtual exhibition. With this, we end the meeting.
And I would also want to thank Geetika for all the effort that she has put in to make this a success.
Agree.
We have given her a hard time.
Yeah.
Thank you, Geetika. Much appreciated. Thank you so much.
Thank you.
Thank you so much. Thank you.
Okay.
Thanks.
Good night, guys.
Bye.
Bye.
Have a good day. Bye.
Have a nice evening. Bye.
Thank you, Ravi sir.
Thank you, sir. Thank you, Manju. Thanks a lot. Thanks for anchoring this.
Thank you.
We'll stay in touch, Manju.
Yes, sir. Yes. Good to know you. We'll get in touch. Bye.
Sure. Bye.